because your priority is to save lives. It has become our commitment. To deliver the ultimate system. With augmented insight. Because a single image can help you change their future. I am.
Everything begins with a simple dot, a single piece of information. And when you begin to connect the dots, data, experiences, needs, ideas, you start learning. That's what humans usually do. That's what I try to do. I could not exist without you. We are made for each other. You have experience, commitment, judgment. I have an endless memory, and I can think very, very quickly. So, if we work together, we can do great things, wonderful things. We can move deeper, faster, safer. We can take better decisions for your patient's health and well-being, together. Thanks to your knowledge, I can assist you in reading every detail of your ultrasound images better and more thoroughly. That's why in Esaote, AI does not only mean artificial intelligence, but augmented insight.
Bueno, buenos días. Por lo que entiendo, un gran día de sol tenemos hoy.
Buenos Aires a pleno.
Y una hermosa mañana vamos a tener nosotros compartiendo acá con todos los oradores que tenemos preparados para esta segunda parte del curso.
Bienvenidos a esta jornada académica que realmente el temario es un lujo escuchar a los máximos exponentes mundiales de esta temática en cada uno de estos ítems, Dario.
Sí, exactamente. Esto, gracias a Diego, tenemos la oportunidad de poder llegar a todos con creo que lo último, ¿no? Lo último que se está hoy en día escuchando a nivel internacional en cuanto a todo lo que sea patología mamaria, desde su diagnóstico hasta los últimos tratamientos. Como ustedes saben, comenzamos formalmente el segundo día de las clases de cáncer de mama, manejo y controversias 2024, gracias a la Academia Humberto Veronese Academy y también a la Universidad de California de San Diego.
Fueron 2 mañanas, el sábado 19 de octubre y que es la jornada de hoy, el 26 de octubre, y gracias a todo el equipo de Tecnoimagen y a sus directivos que apoyan a la formación académica continua en forma gratuita, tenemos una traducción simultánea del español al inglés de cada una de las conferencias.
Bueno, y esto es como siempre, Cari, la página de Facebook, la Comunidad Latinoamericana de Imagenología Mamaria, también su canal en Instagram, en donde la idea es que todos los que hacemos patología mamaria, nuevamente desde su diagnóstico hasta el tratamiento, pasando por la cirugía oncoplástica, etcétera, etcétera, sean tanto médicos, sean tanto técnicos, sean tanto algún otro que esté relacionado con la patología mamaria, podamos compartir, se hagan del grupo. El grupo es abierto, lo único que cuidamos son los buenos modales.
Exactamente, y el trato cordial entre todos. Bueno, los invitamos y que quiero que agenden estas fechas, que son las actividades que va a hacer la Comunidad Latinoamericana de Imagenólogos Mamarios CLIM. Vamos a tener actividades como siempre los sábados, los clásicos de los sábados a la mañana que comienzan a las 10 a.m., que vamos a comenzar el 29 de marzo del 2025. Van a ser 4 sábados en donde vamos a tener a máximos exponentes de Latinoamérica, llevando todas las novedades y también, como siempre, presentación de casos clínicos con manejo multidisciplinarios. Así que agenden estas fechas. ¿Y el presencial, Darío, cuándo va a ser?
El presencial, tenemos el 4º curso internacional teórico-práctico de la Comunidad Latinoamericana de Imagenólogos Mamarios, que habíamos pasado una fecha la semana pasada que lamentablemente no la podemos confirmar por una cuestión de logística, pero seguramente a la brevedad vamos a confirmarle que va a ser seguramente para alguno de los fines de semana de junio o los principios de julio. Pero vamos a confirmarle por una cuestión logística del lugar donde realizar el congreso. No obstante lo cual, sepan que va a estar el presencial, ya estamos trabajando en el presencial 2025.
Que vamos a traer los máximos también exponentes de Latinoamérica. Va a haber siempre, como siempre, intervencionismo, talleres de resonancia, de ultrasonido, inteligencia artificial, todo lo que son novedades y que podemos llevarnos más allá de la teoría a la práctica diaria.
Exactamente, ya estamos hablando por el tema de las pantallas, también para poder utilizarlas y para tener todo listo, ¿no? Para junio de calculo del 2025. Bueno, Cari, vamos a sortear 2 libros. Vamos a sortear 2 ebooks de Karina, Signos en Imágenes Mamarias, una guía práctica para radiólogos y no radiólogos. La autora Karina Pese, como ya les dije, creo que es indispensable para todos poder leerlo. Probablemente también en algún momento del año que viene tengamos la versión en papel, que muchos la están pidiendo, ¿no? Porque lo digital es lindo, pero mucha gente lo quiere tener en papel, así que como una novedad, les comento que hay alguna posibilidad, por más que Cari lo vaya guardando, pero de tenerlo en papel. Y ¿cómo hacen, Cari? Vamos a sortear los libros, y cómo hacen los que todavía quieren comprar o los que quieren comprar el libro vía
Online, bueno, los que
online.
quieran comprar el libro está disponible en la página web www.doctoracarinaps.com.ar. Ahí está la posibilidad de poder hacer la compra online de este ebook. Vamos a presentar a quien es el director del curso, es el doctor Paolo Veronesi, que es el director del programa de mama del Instituto Europeo de Oncología, director de la Dirección de Cirugía de Mama del Instituto Europeo de Oncología, y los directores de Umberto Veronesi Academy, que son el doctor Gabriel Farante, que forma parte de la División de Cirugía de Mama del Instituto Europeo de Oncología y es director de la Umberto Veronesi Academy, el doctor Antonio Frazón, que es codirector de la Umberto Veronesi Academy y es titular del grupo de mama del Hospital Israelita Albert Einstein de San Pablo, Brasil, y el codirector también de Umberto Veronesi Academy, el doctor Alberto Rancati, que es director de Oncoplástica, de la División de Oncoplástica de la Universidad de Buenos Aires, Argentina. Nosotros, quienes estamos presentando las conferencias, el doctor Dario Schejtman, director médico, Centro Médico Preventus y staff del Hospital Bellison en Israel, y codirector junto conmigo de la Comunidad Latinoamericana de Imagenólogos Mamarios.
Y la doctora Karina Pesa, que es jefa de sección del diagnóstico e introducción mamario del Hospital Italiano de Buenos Aires y también directora de CLIM, como todos conocen. Tenemos numerosos conferencistas que van a estar a lo largo del día de hoy. Creo que hay 7 charlas, los cuales vamos a ir presentando a medida que cada uno de ellos vaya dando su charla. Y bueno, vamos a dar la apertura de este segundo día del curso. ¿Te parece, Cari, con Gabriel?
Perfecto, invitamos al doctor Gabriel Farante a darnos las palabras de bienvenida. Bienvenida, Gabriel.
Gabriel, bienvenido y muchas gracias nuevamente.
Muchas gracias, Darío, muchas gracias, Karina. Sobre todo a ustedes que son los coordinadores y también a la gente que trabaja detrás de bambalinas, como se dice, sobre todo el coordinador técnico Alexander y todo el grupo, que serían innumerables nombres para agradecerles a todos, porque realmente la eficiencia de este curso se debe sobre todo a ustedes que trabajan desde allá, desde Tecnoimagen. La revista Newsweek ha publicado en estos días el ranking de los mejores hospitales especializados del mundo en oncología en 2024. Esta lista es fruto de una investigación de Newsweek asociado con la Sociedad de Investigación Global Statista para clasificar los mejores hospitales especializados en el mundo en al menos 10 especialidades, entre ellas esta, la oncología, que en el 2024 incluye el estudio de los 300 mejores hospitales en oncología. Una vez más, este año, en los 3 primeros lugares, considerando muchos parámetros, pero fundamentalmente los relacionados con la clínica, la cirugía y la investigación, se encuentra el MD Anderson de Houston, Texas, el Memorial Sloan Kettering Cancer Center de New York y la Mayo Clinic de Rochester, los 3 en Estados Unidos. ¿Por qué esta información? Justamente porque una vez más, como sucedió en años anteriores, el grupo de docentes y conferencistas de este curso está formado por representantes de estas 3 instituciones, las 3 mejores del mundo. 6 representantes del Memorial, 2 del MD Anderson, tuvimos la semana pasada, y 1 de la Mayo Clinic, que tendremos hoy al final la profesora Judy Boogie. Además de representantes también de la Columbia University, de la University of California, San Diego, la semana pasada, y 3 representantes del IEO, que es el segundo, según esta estadística, el segundo en Europa, sobre 300 en todo el mundo, considerando que este año recién cumple 30 años de existencia, por tanto es muy meritorio que ya el IEO esté en este ranking. Todo esto para remarcar y subrayar que el nivel científico de nuestro curso está constituido por representantes de las instituciones más prestigiosas del mundo en oncología y por tanto nos permite mantener este curso en el más alto nivel de información y actualización con los descubrimientos y novedades de última hora. Tanto en la parte clínica, médica y quirúrgica, como en la parte de investigación de base y experimental, comprende todo esto. Y en segundo lugar, por otra parte, queremos saludar a nuestro amigo y colaborador, profesor Román Rostaño, profesor en radiología y miembro de número de la Academia Nacional de Medicina Argentina. Es un verdadero honor contar en nuestro grupo de la Umberto Veronesi Academy con el profesor Román Rostaño, maestro de la radiología argentina y latinoamericana, reconocido por su capacidad de transmitir conocimientos con una claridad y pasión inigualables, que ha formado y sigue formando generaciones de especialistas que encuentran en él no solo un referente académico, sino especialmente un modelo a seguir. Su compromiso con la innovación y la excelencia profesional es una fuente de inspiración para todos los que tenemos el privilegio de su sabiduría. Gracias por ser una fuente de inspiración para todos nosotros. Y desde los primeros años en que iniciamos nuestra actividad de formación y educación médica en Argentina y en América Latina, y viajábamos con el profesor Umberto Veronesi, pocos nos conocían, algunos ni aceptaban nuestras propuestas científicas. Él estuvo siempre en primera fila, en primera línea, dándonos siempre su apoyo científico y logístico incondicional. A él va nuestro saludo, agradecimiento y un gran abrazo. Finalmente, una vez más, deseo les presento el libro Manejo del cáncer de mama, que es la radiografía perfecta de las actividades clínicas, quirúrgicas, de radioterapia, de radiología y de todas las disciplinas y especialidades que en el IEO de Milán trata día a día en un modo o en otro el cáncer de mama. Cuando en 2020 publicamos la primera edición sobre el manejo del cáncer de mama, hicimos conocer a la comunidad científica médica la contribución y el aporte científico de los médicos miembros del programa de cáncer de mama, dirigidos por el profesor Paolo Veronesi del Instituto Europeo de Oncología de Milán, programa del cual participan todos los especialistas del instituto que trabajan en sus respectivas disciplinas en el manejo de cáncer de mama. Hoy, a 4 años de la primera edición y en el 30º aniversario de la creación del IEO por el profesor Umberto Veronesi en 1994, publicamos la segunda edición del manejo de cáncer de mama, que incluyen los diversos enfoques multidisciplinarios, incluidos la cirugía mamaria, la radioterapia oncológica y la biología relacionadas con las radiaciones, la oncología médica, la anatomía patológica, la radiológica, la farmacología, la farmacocinética, los avances en la genética y en la biología molecular, y la bioestadística, la psicooncología, así como otros temas particulares relacionados con el manejo del cáncer de mama. El interés y la preocupación en relación al cáncer de mama ha ido aumentando considerablemente en las últimas décadas debido en particular a la creciente incidencia del cáncer de mama en los países industrializados y occidentalizados, en los cuales sigue siendo uno de los problemas más comunes y temidos por las mujeres. Se calcula que en la actualidad en Estados Unidos 1 de cada 3 mujeres consultará al médico por una enfermedad mamaria o por una sospecha de tal patología. 1 de cada 5 será sometida a una biopsia mamaria y al menos 1 de cada 10 mujeres desarrollarán durante su vida alguna variedad del cáncer de mama. Los rápidos avances en la comprensión de la biología molecular y las mutaciones genéticas asociadas a un alto riesgo de cáncer de mama han generado un optimismo a la espera que se puedan desarrollar nuevos métodos más específicos para identificar el riesgo de una mujer de padecer cáncer de mama, para prevenir y si no, al menos detectar la enfermedad en una etapa más temprana y en caso de que esto suceda, curarlo con una toxicidad mínima. En definitiva, esta segunda edición representa un compendio de contribuciones fundamentales de más de 50 médicos del programa de senología del IEO, que por ahora tiene una publicación limitada e interna, pero debido a numerosos pedidos estamos programando una edición en castellano y en inglés para todos aquellos médicos que nos solicitan constantemente mayor información científica documentada. Finalmente, les anuncio que el próximo año vamos a hacer una pequeña modificación en las fechas, pasando de los 2 últimos sábados de octubre a los primeros 2 sábados de la primera semana de noviembre, es decir, que en el 2025 el curso será desarrollado durante los sábados 1 y 8 de noviembre. Gracias a todos los coordinadores, a todos los participantes científicos, a todos los técnicos, como dije anteriormente, y les deseo a todos los participantes, los oyentes, que aprovechen de esta importante actividad de formación y educación médica y científica. Muchas gracias.
Gracias, Gabriel, muchísimas gracias. Bueno, realmente, como dijimos, muy orgullosos de poder presentar y llevar de tu mano al Instituto Europeo de Oncología y a Umberto Veronese Academy a todo el público latinoamericano. Bueno, Cari, si te parece, empezamos ya con las jornadas del día. Gabriel, vamos empezando, así tratamos de llegar en horario.
Excelente, Darío. Bueno, muchas gracias al Instituto Europeo de Oncología por la posibilidad de coordinar estas jornadas que la verdad son de un nivel supremo. Vamos con la primera conferencia a cargo del profesor Dr. Giuseppe Viale, que es director de la División de Anatomía Patológica del Instituto Europeo de Oncología, quien nos va a hablar sobre biomarcadores en cáncer de mama. Va a estar moderada la presentación por el profesor doctor Hugo Japaze, que es anatomopatólogo, que vive en San Miguel de Tucumán. El doctor tiene un reconocimiento próximamente con un premio del presidente Sarmiento en el Senado a reconocimiento en la Argentina a su trayectoria. Así que le damos la palabra. Bienvenido el profesor Giuseppe Viale.
First of all, thank you for the invitation to participate in this interesting meeting. I will spend my next maybe 20 minutes by addressing the diagnostic biomarkers in breast cancer. So let me start going back to the end of the last century, when the community of the breast oncologists made a very important shift in the paradigm for the systemic treatment of patients with breast cancer. Until those days, the systemic treatment was exclusively based on the risk assessment, in other words, on the prognosis of breast cancer based on the stage of the tumor. But at the end of the last century, under the guidance of Professor Aaron Goldich, there has been this shift in the paradigm by focusing the attention on the expected responsiveness of the tumor to the different therapeutic approaches. So not only prognosis, but prediction of the response was important to inform the treatment. And for us as pathologists, this has meant that we had to add to our obsession for measuring the amount of tumor. How large is the tumor in the breast? How many are the lymph nodes with metastasis, etc.? To add to this obsession something new, that was the biological characterization of breast cancer. So there was the introduction of the concept of theranostic biomarkers. Oh, this sounds like a very difficult term, theranostic, but this term is a combination of diagnostic and therapy. So what are those biomarkers that will inform the choice of the therapy? For more than 3 decades, we only had 2 available biomarkers: the estrogen receptor for the endocrine therapy and the HER2 status for the entire 2 therapies. And we have learned how to subtype all breast cancers according to the expression of these two biomarkers in the luminal, HER2 positive, and triple negative breast cancer. So this was for more than 3 decades. But in the last few years, new biomarkers have appeared with their related therapies. And so nowadays we have a list of diagnostic biomarkers. We have PD-L1, we have TROP2, we have the low expression of HER2, we have mutations in the BRCA1 and BRCA2 gene, we have mutations in the PIK3CA, AKT, PTEN axis, and we have mutations in the estrogen receptor gene. And for each of these new biomarkers, we have a specific therapy. These therapies have been already approved in the metastatic setting, and some of them have already moved to the early setting. So let's start focusing on some of these new biomarkers. What is HER2 low breast cancer? Well, the definition is that breast cancer with an immunohistochemical score of 1+ or 2+ without the amplification. This tumor represents approximately 2/3 of all the tumors in the metastatic setting. And the prevalence of HER2 low expression is higher in the so-called luminal tumors, where they represent more than 70%, and they also represent some 50% of tumors that are triple negative. So HER2 low expression is a very common biomarker for breast cancer patients. It is important to consider that the low expression of HER2 actually does not define a new molecular subtype of breast cancer. It is simply a biomarker that is common to all the molecular subtypes that we already know. But it is also important to remember that the introduction of the concept of HER2 low has to change our way of looking at HER2 in breast cancer. Because in the past, we have always considered HER2 as a specific target for a specific therapy. Therapy with drugs that will inhibit the HER2 pathway, and at the same time, they will stimulate the immunoreactivity of the patients. But when we go to the low expression of HER2, this is not longer a specific target for a specific therapy. It is just a ploy. I see the HER2 low expression as a window in the cell membrane that will allow some drugs that will act like Trojan horses enter in the cell, where they will release a powerful cytotoxic inside the neoplastic cell. And then the cytotoxic payload may also go in the microenvironment and also kill the neighboring tumor cells, even in case these neighboring tumor cells would not express any HER2. The introduction of the new antibody drug conjugates, like trastuzumab deruxtecan, have been proven to be extremely effective in patients with metastatic breast cancer with a low expression of HER2, showing an improvement of progression-free survival and also of overall survival. But since the expression of HER2 in breast cancer is a continuum, we also have some tumors that will express very low quantities of HER2. These tumors that have been scored with an immunohistochemical score of 0 actually may show some immunoreactive cells, 10% or less. And these tumors also may benefit from the introduction of trastuzumab deruxtecan in terms of progression-free survival. Another important biomarker is testing of germline BRCA. Again, we have a paradigm shift here, because we used to test for these mutations patients in order to perform risk assessment. But nowadays, tumors in carriers of BRCA mutations may benefit both in the advanced and in the early setting of new therapies based on PARP inhibitors. So these mutations are becoming a theranostic biomarker. So if these are theranostic biomarkers, we have to test many more patients, because in the advanced setting, all patients with recurrent or metastatic breast cancer should be tested to identify patients that are candidates for PARP inhibition. And also in the early setting, according to the results of the Olympia study, patients with high risk early breast cancer that have been treated with neoadjuvant or adjuvant chemotherapy should also be tested. Mutations in the PI3K, AKT, mTOR pathways are present in almost 70% of patients with breast cancer. The most common alteration is mutations in the PIK3CA gene, but we may also have amplification of this gene, loss of heterozygosity of PTEN, and then mutations or amplification of the AKT genes. And we know that there are already at least a couple of drugs that have been approved for treatment of patients with advanced breast cancer of the luminal subtype. Finally, mutations in the ESR1 gene. They have been discovered in breast cancer in 1997, but their role in the resistance to endocrine therapy has been established only in 2013. It is important to remember that the prevalence of these mutations depend on the prior duration and setting of endocrine therapy. They are very rare in early breast cancer and also in metastatic breast cancer not treated with endocrine therapy. But their prevalence increases according to the use of aromatase inhibitors, peaking to a prevalence of almost 60% in patients that have been treated for metastatic breast cancer with CDK4/6 inhibitors. Again, a drug has been already approved for advanced breast cancer in the postmenopausal women and in men that have mutations in the ESR1 gene. We know that there are more than 200 mutations until now described in the ESR1 genes that will lead to changes in the amino acids or some deletions. These mutations are commonly seen in the ligand binding domain of the gene. And we know that approximately 50% of all the resistant cases to endocrine therapy are associated with such mutations. We may look for the mutation in the ESR1 gene both in the tissue biopsy or in liquid biopsy, including circulating tumor cells and cell-free DNA, using different detection assays, including some assays that have been approved as companion diagnostic by the FDA. And so, coming to the end of my presentation, it is important to remember that in addition to the original biomarkers, estrogen receptor, progesterone receptor, and HER2 status, now the recommendations is that in all patients with metastatic disease, we should offer testing for PIK3CA mutations, AKT mutations or alterations, mutations in the ESR1 gene, and germline mutations in BRCA1 or BRCA2 genes. But this is not the end of the story, because we know that there are additional biomarkers and related therapies that are currently under study, including HER3, the androgen receptors, mutations in the HER2 gene, LIV1, and maybe other possible biomarkers. So, what is now the changing horizon of breast cancer? So we have the classic subtypes, luminal, HER2 positive, triple negative, but for each of these individual subtypes, we have different subtypes based on the expression of these biomarkers, or these theragnostic biomarkers, that will inform the systemic treatment in the metastatic setting, as well as for some of them in the early setting. So what would be the therapeutic algorithm of tomorrow? We have to consider that we will be able to identify more than one biomarker in many breast cancers. For instance, metastatic triple-negative breast cancer may have mutations in the BRCA gene, may express PD-L1, may have mutations in PIK3CA, may express HER2, low quantity of HER2, may express HER3, it may express TROP2, androgen receptor. So these patients with tumors with multiple theragnostic biomarkers actually will have multiple therapeutic options that sooner or later these therapeutic options will be in the very same lines of treatment. These drugs are very effective in improving the chances of cure in the early setting or survival in a metastatic setting. Certainly, cumulative toxicity will likely prevent a combination of many of these drugs. So the next important question is how we'll be able to design sequences of treatment. Because we are good enough in identifying candidate patients for different treatments, but still we are unable to predict who will respond and how large will the benefit be. So what we have to learn is how to predict the magnitude of benefit of the different treatments in order to be able to rank them in a sequence that will ensure the largest benefit for our patients. Okay, it is likely that we will need more accurate predictive models, possibly based on new and more sophisticated approaches, maybe NGS, maybe digital imaging or artificial intelligence. But certainly we have to be able to ensure for each of our patients the best possible sequence based on the expected magnitude of benefit. And with this, I thank you very much for your kind attention, and I will be happy to address any question you may have.
Hi, Beppe. How are you? Nice to...
Doctor Japaze, me parece que
Ay.
el doctor Viale no nos está escuchando. Puede, si no, hacer un
¿Me escuchas?
comentario. Ok.
Okay. Excellent conference, Beppe. Nice to see you again.
Thank you, Hugo.
Voy a decir mis preguntas en español. Tengo dos. La primera, ¿cuál es el rol de la patología convencional en la era del tratamiento personalizado? Esta es la primera. Y la segunda, en la práctica diaria, ¿cuándo indicar los paneles multigen en grupos prognósticos o en todos los casos?
Okay, let's start with the first question. I think that precision medicine should also be based on the precise evaluation of the morphological and biological characteristics of the tumor by using traditional approaches. Then all the questions that will remain, for instance, how to define the magnitude of benefit, possibly will need some more sophisticated approaches. It may be gene expression profiling, it may be wide gene exploration for mutations, but certainly we have to combine the traditional approach with these new technologies. And with regard to the multigene, these are certainly a valid prognostic parameter for patients with hormone receptor positive disease in the early setting in order to identify those patients that may be spared from chemotherapy. So we are actually using these multi-gene tests whenever we are in doubt about the possible benefit of additional chemotherapy to endocrine treatment for patients with a node-negative disease or for patients with breast cancer with 1 to 3 positive nodes.
Gracias, Beppe. Estas fueron mis preguntas. Muchas gracias.
Thank you.
Ok, vamos a continuar. Entonces, muchas gracias, Hugo. Thank you, Giuseppe. Vamos a continuar con la próxima conferencia. Voy a introducir a la doctora Janice, que va a dar la clase Mamografía con contraste, Implementación e indicaciones. La doctora es jefa asociada de la División de Imagenología Mamaria de la Columbia University de Nueva York. Dr. Sang, you can share, now you can You can share your conference when you want.
Great, thank you so much for that introduction. So in the next 20 to 25 minutes, I'll be discussing contrast mammography and just give a general overview. So we'll begin by very briefly reviewing the limitations of mammography, because it's really these limitations that led us to explore alternative techniques such as contrast mammography. We'll review some basic principles on how to perform a CEM, and then spend the majority of our time going through several indications where CEM could be of value. We can all appreciate that mammography is the primary modality we use for breast cancer screening. And although it's effective, it does have a number of limitations. And probably the most significant limitation is the fact that its sensitivity depends heavily on the density of the breast. So if you have a fatty breast like the one shown on the left, mammography is very, very good, detecting more than 90% of breast cancers. But if you have extremely dense breasts, then that number falls to less than 40%. And, excuse me, CEM is a vascular-based imaging technique. And the vast majority of our experience from vascular-based imaging really comes from what we have learned from breast MR. So based on doing MR for so long, we know that mammography is not nearly as good as we thought it was. There's been a number of trials. Wendy Berg's Akron 666 trial. Women had 3 years of negative mammogram, 3 years of negative screening sono. They do 1 MRI. They find an additional 15 cancers per 1,000. Chris Comstock talked to you about the EA1141 trial, comparing tomosynthesis and a abbreviated or fast MRI done in less than 10 minutes. Even in that setting, the cancer detection rate using a vascular-based technique was more than double that of tomosynthesis. More recently, in the DENSE trial, these were average risk women with extremely dense breasts. When they did a single MRI, they found an additional 16 to 17 cancers per 1,000 women. We know that MRI is more likely to detect higher grade and invasive cancers, and if you use MRI, you're able to reduce the interval cancer rate. So what have we learned from MRI? We've learned that contrast is really key. If you want to find more cancers at an earlier size and stage, if you want to reduce the interval cancer rate, you have to do some kind of vascular-based imaging. And that really brings us to what is CEM. CEM is basically a mammogram performed after giving iodinated intravenous contrast. And just like with MRI, it's based on the principles that cancers as small as 2 millimeters in size, they develop neovascularity. Those vessels are not normal vessels, they're leaky vessels, which allows contrast to accumulate in areas of cancer that we can detect on imaging. And the primary advantage of CEM over breast MRI is the fact that it's far less expensive. In the US, MRI can cost several thousands of dollars, but the cost of the contrast is less than $50 per patient. And because we use existing mammographic equipment, this has the potential to allow far more women access to a vascular-based technique. So how do we do a CEM? You basically give the contrast intravenously, you wait 2 minutes, and then you position the patient as if they were having a normal mammogram. Each time a view is taken, 2 views are taken almost simultaneously. The first is called a low energy image that looks like a regular 2D mammogram. And then immediately after that, we take a high energy image, which is used to create a recombined image, which highlights areas of contrast uptake. This is the functional information we usually get with breast MR. So if you wanted to start doing CEM, there are a couple things obviously that are necessary. You must have a CEM capable system. Most of the vendors offer CEM capability. In order to start doing CEM on these units, it's basically an upgrade of the software as well as installation of a special filter. But again, you're using existing mammographic units, so it's far less expensive to upgrade your unit compared to getting more access to MR. Because we are giving iodinated contrast, you have to have the mechanisms to do that as well as the staff. We give the contrast at the same dose and rate as we do for CT. Because it is iodinated contrast, you have to have some ability to check renal function. Again, this will depend on your institution. The criteria here are what we used to use at Sloan Kettering, but this will vary depending on where you work. And then, of course, because you have the potential for contrast reactions, you have to have the staff as well as the equipment to help manage any kind of a contrast reaction. So if you start to do, or you're thinking about starting to do contrast mammography, there are a couple of settings that are listed here where CEM can be of added value. And I think the important thing is once you start doing CEM, you start with one indication. You get more and more experience with that indication. And then once you are more comfortable with the technique, then you can start opening it up to various settings. But we'll go through each of these and talk about some of the data supporting the use of CEM in these settings. One of the earliest uses of contrast mammography was really for further evaluation of abnormalities detected on screening mammography. This table summarizes some of the early data, and what you can see is not only does having contrast on board improve your sensitivity in terms of cancer detection, importantly, at the same time, you're able to improve your specificity. You're able to further downgrade your false positive recalls. And so, for example, in the LOBE study, specificity went from 40% on a regular mammogram to almost 90% with a contrast mammogram. And why is that? Well, just very similar to MRI, if something does not show enhancement, it's very unlikely to represent a cancer. There are a couple of exceptions, but in a general rule, just like with MRI, if something does not enhance, we feel comfortable in ignoring it. And that gives you that improved specificity. So here's an example of a right mammogram, the CC view, where the patient presented for a palpable abnormality. Straight back behind the nipple, you can see that there's an obscured mass. Normally, you would have to do additional imaging on this patient, but on the recombined image, you can see that there's absolutely no enhancement, so you can completely ignore this finding. Another example of bilateral CC views where there's an asymmetry in the retroglandular fat of the left breast. Normally, this patient would have to be recalled for spot compression views, a 90 view, probably a targeted ultrasound. But again, no enhancement, no need to work this up any further. The second area where contrast mammography has shown to be of potential value is in preoperative staging, when a patient's newly diagnosed with breast cancer, determining how much disease there is in the breast. And when you think about preoperative staging, there's really kind of two different aspects. We're trying to evaluate the extent of disease in the breast. So that means not only the index lesion, is there multifocal or multicentric disease? Is there disease in the contralateral breast not seen on the mammogram or ultrasound? But then also we want to look for evidence of nodal metastases. CEM is not going to be as good as MR in terms of these nodal metastases. So if you use contrast mammography in the setting of preoperative staging, you have to do this in conjunction with a breast ultrasound. Excuse me. Preoperative staging was actually the indication that we first started using contrast mammography for at Memorial Sloan Kettering about 10 years ago. We initially did a very small prospective study. It only included 50 women. But in that study, you could see that the sensitivity of CEM was equivalent to that of MRI in terms of detecting the index lesion. The problem was really additional lesions. And in this case, in terms of detecting additional multifocal or multicentric disease, MRI was clearly better, detecting 94% compared to 56% with contrast mammography. But where contrast mammography really showed value was the fact that there were far few false positives. With MRI, 1 out of 4 women were asked to undergo another biopsy that turned out to be benign, compared to only 4% with contrast mammography. And so this whole concept of this theme of reduced sensitivity but improved specificity compared to MR is something that you're going to hear over and over. These are some images from that initial study. The right mammogram, the subtraction MIP image from the MRI shows a unifocal mass. And the recombined image from the contrast mammogram, you can see how closely they mimic each other in size and shape. This is another patient on the MRI. Again, you can see she's got this extensive mass and non-mass enhancement along the inferior aspect of her breast. The contrast mammogram is not nearly as pretty, but you can certainly see that there is pretty extensive mass and non-mass enhancement inferiorly. Now, these images are from over 10 years ago. The technology has improved significantly, and so has our interpretive skills. So some more recent data. This is Ava Fallenberg's publication. She was looking at CEM compared to MR for additional lesions in patients with known cancer. And again, the sensitivity of MRI was a little bit better than contrast mammography, but CEM had a higher specificity. Mark Lopes published a paper last year specifically looking in women with invasive lobular cancer from an imaging standpoint. ILC is very, very difficult to appreciate the extent of in the breast because it's very, very subtle, both on the mammogram and on the ultrasound. More often, there is multifocal disease that we aren't able to detect on conventional imaging. And what you can see from this table is that there was no difference in sensitivity between MRI and CEM, but there was a statistically significant improvement in specificity. So I think, what the data shows in terms of preoperative staging at this point, CEM is probably almost as good as MR, maybe not quite as sensitive, but you will get fewer false positives. And at a time where many women don't necessarily have preoperative staging for all cancers, this could be an easy, fast, inexpensive alternative. Now, if you can use contrast mammography to get an idea of how much disease is in the breast, then it makes sense that you can use CEM to evaluate response following neoadjuvant therapy. And at least in the United States, when somebody completes neo, they typically get a post-neo MRI as well as a mammogram. And the benefit of doing the CEM is that you can do those very quickly at one visit instead of scheduling the patient separately for the mammogram and then also for the breast MR. And in terms of interpretation, post-neo breast MRIs are probably the easiest studies that a radiologist has to read because there's an initial study before starting the chemo which showed you where the disease is, how much disease is there. And the only question we're really trying to answer on the post-neo imaging is that enhancement at that area? Is it smaller? Has it gone away? Or is it still there? It's very, very unlikely to develop new cancer while you're on neo. So really, we're just trying to answer one very, very specific question. And when you are using CEM compared to MRI in that setting, there have been several single institution, again, very small studies, but what these have consistently shown is that CEM is really not inferior to MRI in this very specific setting. So that's another area where CEM can be used. Here's an example of a 48-year-old who had triple negative breast cancer. She presented with an palpable abnormality in the lateral left breast. She had a sonographic correlate. She also had abnormal nodes, and then these were biopsied and shown to be invasive cancer with axillary metastases. She had an initial staging breast MR, and again, you can see where the disease is. That's a whole purpose of this initial breast MR. And then after she completed neo, she was one of our study patients, so she had a contrast mammogram as well as a breast MR. And on the contrast mammogram, the recombined images, you can see the clip where the cancer was, and she certainly has residual mass and non-mass enhancement surrounding that clip. And when you compare that to what you see on the MRI, you can see how close the two approximate each other in terms of how much residual disease is left. And in this patient, she went for excision and she had residual disease spanning about 4 centimeters. This was another patient who presented with a palpable right breast mass, obvious mammographic correlate. The sono finding was biopsy. This was IDC, and then she underwent neo. She had a contrast mammogram after completing neo. On the regular portion, the low energy images, you can see the clip where the biopsy was performed. There's still an asymmetry surrounding it. Is that residual disease or not? But if you look on the recombined images, there's absolutely no associated enhancement, suggesting a complete imaging response. And when she went for a surgical excision, there was no residual disease. The final area I want to touch upon, which to me is probably the most exciting potential use of contrast mammography, is screening of the intermediate risk patient. We already know that MRI is the best test in terms of cancer detection, but again, because of the high cost, because of the limited access, it's really restricted to women who are at greater than 20% lifetime risk. There are many, many more women in this intermediate risk category, the millions of women with a personal history of breast cancer, the thousands of women diagnosed every year with ADH or LCIS or some other lesion increasing their risk for breast cancer, the 50% of the screening population that has mammographically dense breasts that we know mammography is not as effective in. All these women need something better than a regular mammogram or tomo or even screening breast ultrasound. This is really an area where we're starting to explore. There have been a couple papers looking at CEM for breast cancer screening. In all of these, the sensitivity was about 90%. If you compare that to what is normally seen on the regular mammogram, it was only about 15%. In terms of the incremental cancer detection rate, how many additional cancers were detected? It ranged very widely. At Sloan Kettering, it was about 7 per 1,000, all the way up to 24 per 1,000 at Mayo. And at least in our experience, we were able to maintain a high specificity. When you talk about comparing CEM with mammography and ultrasound, I think things to remember is that with a CEM, you do not need a separate mammogram, which is more convenient and reduces your need for additional imaging. Really, screening breast ultrasound is widely used. The problem with screening breast ultrasound is the PPV3. For every cancer you find, you have to do about 10 benign biopsies. This is not true with CEM or breast MR. Again, with MRI, you probably do find the most cancers consistently compared to the other modalities. But the problem is that you do have BioRes 3 recommendations. You do have the problems with the cost of the study. Just a couple of examples. This is a woman with dense breasts. You can see she's got a very difficult mammographic pattern. Even in retrospect, you don't really see anything, but very easily in the upper inner quadrant, in about 2 seconds, you see that there's an enhancing mass, and biopsy of a sonographic correlate was IDC. We did a lot of CEM for women who have a history of breast cancer because these breasts are very difficult to read. The patient has distortion from the surgery. She has trabecular edema. She's got skin thickening. It can be very difficult to detect a breast cancer recurrence, especially to define that recurrence early. And CEM was very good in this setting. On the recombined images, again, you can see multiple masses extending anteriorly from the lumpectomy site. Even if you do a compression view on the regular mammogram over that area, there's really no underlying anatomic abnormality. In this case, biopsy of sonographic correlate confirmed recurrent disease. Another example, patient with a history of left lumpectomy, and the regular mammogram was normal, but on the recombined images, you can see a mass lateral to the lumpectomy site. This one had no sonographic correlate, but when this underwent biopsy, this was recurrent ILC. We see not only mass, but we also see non-mass enhancement. This is a woman with a history of LCIS. The mammogram was negative, but on the recombined images, you can see this non-mass enhancement centrally in the breast. No sonographic correlate. When this was biopsied, this was DCIS. In terms of data, the CMIST is a prospective multi-center trial. Chris Comstock is the PI. This will hopefully give us some of that initial data comparing CEM with tomosynthesis as actively accruing. And so hopefully, relatively soon, we hope to have some at least initial results. What are some problems with CEM? It's much harder to institute a CEM program than it is to do a regular mammogram. You need staffing, you need space to put in the IV, to screen women, to do renal function testing. At least in the United States, the fear of a contrast reaction is probably one of the larger barriers. The contrast reaction rate of CEM contrast is about 3 times higher than that of a breast MR, although most of those contrast reactions are going to be very, very mild, but you are still at increased risk for a reaction. Most reactions recur within a couple minutes of injection while the patient is still in the department, but it is very important to screen patients properly in order to minimize the risk of contrast reactions. There is increased radiation associated with the CEM. Again, it depends on the vendor. It depends on the size of the breast. It is higher than a regular 2D mammogram. It's higher than TOMO. It's less than the combination of a mammogram and TOMO, which many centers still do. And of course, you have limited visualization of certain parts of the breast, just like with any other mammogram. So again, it's really the limited sensitivity and specificity of mammography that really led us to explore alternative techniques. We've had such good experience with breast MR, but because of the high cost and the limited access, CEM is a feasible alternative and really has the potential to improve breast cancer in both the screening and diagnostic setting. And I am happy to take questions if there are any.
Thank you very much, Dr. Sang. And I have 2 questions. One, that you talk about the MRI and contrast mammography.
Mm-hmm.
What do you think that is the future for contrast mammography? You think that is at the same level that MRI?
I think it's going to be not as good as MRI. I think MRI is always going to be a little bit more sensitive. You know, it's with a contrast mammogram, it's still a 2D image where you have that where you have the tissue projecting over each other versus the MRI where we can see clearly through the breast. So I think MRI is always going to be a little bit better, but I think CEM is so much better than what we are using in terms of TOMO and ultrasound that there's certainly a role. But I think in high-risk women, they should still have the breast MRI. This is more for that intermediate risk women where they don't qualify for the breast MR or they're unable to get the MR.
Okay. And the other one, what is your advice for a doctor or institution that wants to start to use this method? Where or how they begin to start?
I think, and actually, I just moved to Colombia recently, and we're going to start a CEM program there. And so I think it's start with decide what you're going to do CEM for. Are you going to do it in staging? Are you going to do it for a screen? Start with one indication just to get more experience with that. In terms of the practicality, if you do MRI, you have to set it up very similarly, meaning you have to have staff to screen the patients in advance, know who needs renal function tests, who's had a history of prior contrast reaction. We schedule them about, if a patient has a 10 o'clock appointment, we have them come about 45 minutes earlier in order to get the IV access and to get all the, the screening done. And then the study itself takes an hour in terms of putting the IV in and monitoring for contrast reaction, everything like that. So I think it's just starting with one indication and then start with a small volume, get everything kind of rolling smoothly, and then you can expand your program.
Okay, thank you very much, doctor. We need to continue with the program, but thank you for your lecture. Thank you.
Vamos entonces con la siguiente conferencia a cargo del profesor doctor Roberto Orecchia, que es el director científico del Instituto Europeo de Oncología, quien nos va a hablar sobre ventajas en el uso de la Proton terapia en cáncer de mama. Y la moderadora, quien va a realizar las preguntas, va a ser la doctora Vanessa Krakowski. Ella es médica especialista en oncología radiante, que forma parte del equipo de radioterapeutas del Hospital Alemán. Bienvenido, profesor Orecchia.
Yes, okay. We can start. My talk will be about the possible advantages in the use of proton therapy in breast cancer, and of course I will start just to give a very short, very brief overview about situation of radiotherapy worldwide. You have to consider that there are more than 7,000 centers with more than 14,000 machines in general. And every year, there are 7.5 million of patients treated by radiation therapy. One of the reasons of this success is because very good result in terms of clinical outcome, but also because the total cost of the general radiation therapy is quite low. Is about 5% of the cancer total burden, the total budget for oncology, and the sustainability is very high because the impact is about, again, only 5% on the health system total cost. Situation of Proton is totally different. You remember the number before. Now we are speaking about 130 operating centers worldwide, with an extreme imbalance in the distribution between high-income countries and low and median-income countries. But not in all high-income countries there is a center for proton therapy. In addition to the number 130 operating center, there are 60 centers, around 60 centers that are under construction. In total, consider the high number of patients treated by radiation therapy, we are speaking about, in total, less than 1% of the patient is treated with proton therapy in of the patient that usually are treated, submitted to radiation therapy in general. There was a strong increase in the last few years, but the rate at which this new facility are opening is too low. What we expected in terms of market is a short, very continuous increase in the radiotherapy market, but also in the projection in the next 5-10 years is also an increase in the number of proton therapy center. Why the reason? Because proton are anyway of interest for radiation oncology. The main reason is due to the very characteristic physical distribution of particle therapy and proton in particular, in which you know very well the physics about the Bragg peak. This is father and son, Nobel Prize more than 1 century years ago. You can enlarge this Bragg peak to cover the target. Two very important things that surely opened a new possibility about radiation, about the increase of proton therapy is the two technical advances. One is the use of active scanning, sort of intensity modulated proton therapy with better conformability, and the second one is related to the single room facility, less cost and less size required for installing this type of machine. Where are we at the moment in proton therapy of breast cancer? One of the first points is the patient selection. That is very important. There was few years ago, 2021, published a consensus statement by the International Society of Particle Therapy, the PTCOC, the Breast Cancer Subcommittee. And at that moment, and today is not different, we have no high level of evidence in favor of proton therapy in terms of clinical outcome. Maybe in some case reduction in toxicity, okay. But for the other indications, we can consider that we have a list of possible indication. but that usually are based on the single decision of the doctors with the patient, or based on the comparative dose distribution between the gold standard with EMRT and other sophisticated X-ray technique and the plan for Proton. In breast, the patient treated by proton therapy use on the left breast, especially when we have to include the regional node irradiation, may be used in breast reconstruction, after breast reconstruction, especially in case of immediate breast reconstruction. In some institutions, is used for partial breast irradiation, especially medially located tumor, complex anatomy in case of whole breast, or specific situation like bilateral tumor, reduced arm mobility, ray radiation, or some types of radio-resistant tumor, for example, maybe breast sarcoma. Dosimetry advantages are in terms of reduction of cardiac toxicity, reduction in radiation pneumonitis, reduction in the dose to the contralateral breast cancer, reduction in the induction of secondary lung cancer, and also in some cases can save the arm and the shoulder function. There are many things to be considered in the treatment planning. The risk is the steep dose gradients, and the risk is to miss the target. We have some uncertainty about the RBE and the LET, the RBE especially because it's considered on average 1.1, but we know that is simply not true. Along the spread break peak, we have a dose RBA that change from about 1 to 0 up to 1 to 3, 1 to 0.4. A range uncertain, the impossibility to adaptive replane, and also in some case we have a problem when we have to overlap in surface. Just some example reported again in the PTCOG consensus about the use. You can see here very nice comparison between EMRT in breast cancer and proton therapy. You can see that, of course, the distribution of the dose is absolutely different. Good conformability also for the use in accelerated partial breast irradiation, the use of patients that have a very extensive field, like, for example, mastectomy one side, intact breast conserving surgery on the other side, the possibility to use with the expander, very nice dose distribution, and also special situation, like, for example, in locally advanced disease and some deformity, like, for example, the pectum carinatum. This is what PTCOG say. This is the real situation. Is a very updated, was published this year, an international survey on PTCOG, in which 29 centers submitted a response, only 35% of the request, the majority in United States, 15, 8 in Europe, 5 in Asia. 93% of the responders are treating breast cancer, and 50% of them have treated more, at least or more, breast cancer. Pencil beam scanning, active pencil beam scanning, the most used, and there is about 50% of the patients that use of the center, they use a moderate hypofractionation. That means 3 weeks of treatment, but the other 50% about conventional fractionation. As I said, the decision to submit, to propose to patient for proton therapy is practitioner determination, patient preference, and, as I said before, comparative plan evidence. In Netherlands, has been applied at the beginning in head and neck cancer, but now has been developed 2 years ago Also, a model-based selection based on the comparison in terms of the NTCP means the normal tissue probability, comparing the best standard with photon and the best standard with proton. In general, we have, on average, we have a delta in terms of reduction in probability to develop complication of about 3% in favor of proton. You can see here what is also a strong reduction based on the comparison of the dose volume histogram in terms of reduction dose, mean dose to the heart, 5 times less, mean dose to the lung, less than 2 times, mean contralateral breast dose, and increased NTCP in favor about 30%. There was a quite recent meta-analysis. As I said, this reflects there are no high level of evidence. This meta-analysis analyze mainly toxicity for accelerated partial breast irradiation. The only severe event reported, the most frequent, is dermatitis, which most report with passive scanning with respect to the new scanning, active scanning, 4% versus 0%. In patients who receive whole breast irradiation or chest wall irradiation, plus or minus regional node irradiation, mostly it's been applied conventional fractionation. In few studies, moderate hypofractionation. Only again 5% of severe events, 45% moderate event. Again, the prevalent severe outcome was dermatitis, 22% after passive scanning, only 6% after active scanning. Other severe outcome is infection, 17%, only 2% after active scanning, pain and pneumonitis, but very limited incidence, less than 1%. With the patient, about 450 patients treated after breast reconstruction, has been observed 141 adverse reconstruction events, 11% infection, and 18% capsular contraction. It's not so different with the reported result for X-ray. In implant reconstruction, 12% of the patient required surgical revision and 19% the removal of the prosthesis. In a case of autologous reconstruction, 3% required surgical revision and 50% a surgical replacement. What about hypofractionation? In our institute, we published a review of the literature, and the conclusion is very simple, that hypofractionation usually is only available for partial breast irradiation, maybe some dosimetric advantage with respect to 3D conformal and EMRT. The dose distribution of proton is better when we use at least 2 or more field. But anyway, the benefit of proton is downside to the limited entity of the CTV. Some years ago, it's been also published in terms of stereotactic irradiation, and this is very important. The location of the tumor may be an advantage in terms of skin sparing and chest wall sparing, only for the lesions that are medially located. And when the GTV, the gross tumor volume, is too close to the skin or to chest wall, there is some limitation in the use of proton. Of course, to have more evidence, we need the ongoing trial. that require a lot of fear, because the primary endpoint of this study, the RATCOMP study, the Danish study, the UK study, you can see that the endpoint is the major cardiovascular events at 10 years, ischemic and valvular heart disease again at 10 years, and probably early result will be reported by the UK study that is planned on patient with local excision or mastectomy, and is the mean hair dose. The patient reported normal tissue toxicity in the breast at 2 years. Just to show you an example of a difficult case that been based on the individual characteristic. One is the patient with pectus excavatum. That is the most common chest wall deformity. The incidence is one case every 1,000 live births, but fortunately is more frequent in male, 5 times more with respect to the female. There is a substantial dosimetry benefit to treating. You can see the difference in terms of DVH in treated chest wall in a patient with pectum excavatus versus conformal photon therapy. The coverage may be the same, but what is important, a very strong reduction in the mean heart dose, more than 95% less, and lungs also, mean lung dose more than 70% less. There was more recently also in silico study on 16 patients with different type, different index of pectus excavatus. And this is quite interesting because in general, as reported in the previous paper, there is an advantage in using proton therapy. But one of the problems is also depend from the inferomedial extent of the internal mammary node when you have to treat also the mammary chain. And if you have a reduced distance between EM and mammary chain and the heart, this is a negative correlation with the reduction of the mean heart dose. So means that also in this case we have to select properly the patient on single individual. This is what we are doing in Milano. We opened a single room facility this year on January, and up to October, we have enrolled 163 patients, all site patients, in planning 150, in treatment 139, and we have completed the treatment in 126 patients. Breast is not allowed, is not covered with few exceptions from the national health system, the Italian health system. In any case, you can see some case we have treated in total only 3 breasts. Usually one was a sarcoma of the breast after total mastectomy. Another one is partial breast irradiation of the left breast, and another is quite large size breast with in a patient with some cardiovascular problems. Today, it is important, as I said, to carefully select patients before recommendation for proton therapy. And because, of course, the dosimetry benefit have to be transformed into a tangible clinical benefit. In our opinion, we believe that the patient that should be with priority selected for proton therapy are young patient with BRCA mutation, patient with collagenopathies, patient with immune disorder, and patient with severe cardiac and or respiratory comorbidity. Or in case of technical changes case, like for example, bilateral tumor and anatomic conformation. But if you look in the internet, in the Google, you can see that in other countries, for example, this is exactly a copy of what is on the website of MD Anderson Proton Therapy Center in Houston. You can see that they offer proton therapy for all the type of tumor, including triple negative, any type of invasive carcinoma, inflammatory, and also for ductal carcinoma in situ, for ray radiation. And also we are offering 2 trials, one for patient for PBI, and the second one is comparison with proton post-mastectomy radiation versus conventional post-mastectomy irradiation. Very briefly, what can we expect in the near future for proton therapy? We have to personalize the treatment. We are in the era of precision oncology. For radiation therapy is not different, and we have to consider not only the anatomy, not only the tumor characteristic, but we have to consider what is the molecular and genetic profile of the patient, with the integration of omic science with new science can be derived from imaging, are more important to develop program for radiomics, to extract features that can predict proper selection of the patient, radiogenomics to identify patient with radio-resistant disease, and dosiomics that is a more advanced tools in order to compare DVH. The general frame is to introduce artificial intelligence tool in all the part of oncology, included for radiation oncology treatment and not only. To realize this goal, we have created a registry, the Power Registry, that we have published recently, that include all the patients that we are treated with proton, biological samples, radiological imaging, clinical data, toxicity profile, radiation plane, etc., etc. This is to create the condition for real-world evidence. What we need in order in terms of sustainability is to reduce the cost and the size of the division. We started in Italy with a very huge synchrotron in Pavia. Now moving to the cyclotron in single room facility, and not only. Anyway, we are speaking about 50 tons, very difficult transportation. Opportunity for the future was a new generation of accelerator, like for example, linear accelerator. The other solution that can democratize proton therapy is the option of eliminate the gantry, that is very expensive and also very heavy. And with new idea about the setup, robotic coach, sitting position, upright position, etc., as traditionally used for the treatment of eye melanoma in proton. Of course, to move this new possible step, we have, of course, also to overcome different challenge, different workflow, and what is absolutely needed is not only a bright setup, but also to integrate a new type of imaging. This is an example of a patient in upright positioning for gantry-free. Breast has been tested in Lyon, in the center of Bérard, in Lyon, and seem feasible, especially including also breast cancer patients with a high satisfaction for the patient in favor of the upright position with respect to the supine position. Thank you very much for your attention.
Thank you, Profesor Orecchia. Excellent presentation. Ahora damos paso a la doctora Vanessa Krakowski, quien realizará la presentación y la moderación. Gracias.
I have a question for you.
Yes.
I had the chance to attend the Miami Breast Cancer Symposium this year, and doctors from Harvard presented a case of course, proton therapy. What they did is they tried a plan with IMRT. She had a mastectomy. They had to irradiate chest wall. And what happened is that when they deliver photons with a VMAT in the IVH, the mean heart dose was higher. But when they did protons, when they tried with protons, the left descendant artery received. With that being said, they asked Dr. Timothy Bellan, what would you do? And he said, I don't know. Would you go with a higher left descendant artery dose, with a higher heart mean dose? And again, how do you contour? The only constraint we know is mean heart dose, and we try to get closer to zero because each grade delivers a 2% morbid mortality risk.
We don't have enough experience, as I mentioned it before. We have treated really few breast cancer up to date. We did not observe the point that has been reported by you. May be possible because anatomical condition is very important, and when we speak about proton, we have to apply proton in a patient, in a person. And so different size, different shape. We usually in IAO, you know that we are treating a lot of breast cancer, operated more than 3,000, and 50% receive also radiation therapy. For each of patient, we not only calculate the mean hair dose, but also we calculate the dose identified in the apex of the ventricle, what is the right position of the left descending artery. Of course, we are using similar tomotherapy, so means that we use VMAT, very similar to VMAT. The dose we receive is under the constraint, but a little dose received. For proton, again, I cannot answer based on my experience, but in general, the only thing when we have some difficult case, and this specialty case, the only possibility is to have two different plans. One with VMAT and the other one with proton. And the communication with the patient is, okay, proton in theory is better, but not for all.
Great. And since how do you contour, or what's your constraint for the left descendant artery?
We contour using an auto-contouring system, and that now is faster than in the past. We have introduced it because it's a very busy department, and this type of tool is very useful. Of course, there is a second look from the physics and from the medical doctor, from the radiation oncologist, in order to check, because one thing is to contour the entire volume of the heart. The other point is to identify exactly what you can see on the CT scan. Okay.
And do you use like AI to auto contour structures? Artificial intelligence develop or?
Yeah, we are trying also to use at the best is an initial experience on that, but I believe that especially in this type of operation, like especially for repetitive procedures like contouring and other, also creation, for example, for identifying the structure is to create synthetic CT using maybe MRI, maybe more useful for some substructure. You can transform MRI in synthetic CT scan that is useful. You can create a new type of imaging. Of course, you have also to consider that is a lot of work, a lot of job more, and any procedure is more expensive.
Of course. Well, it's for the value.
Also, not trivial question for professionals that require a long time, a very, very high level of attention.
Well, it's about costs and it's about the value. It's a great value, actually.
Cost is an issue for Proton because cost is depends. It's very different from United States, in which the patient pay a lot of money, and different in Europe in general. For example, just for your information, but you already know, probably others don't know, is on average is from 30 to 35,000 euro for a cycle. You consider that in Italy is cheaper, and the reimbursement from the national health system is 21,000 euro. Means that there are absolutely no gain, no margin.
No margin.
If you consider the investment, if you consider the procedure, if you consider all the general cost, energy, not the last, we are exactly at the break even. So means that gain one and spent one.
Thank you, Vanessa. Thank you, Roberto. And I will continue all day talking about that because it's very interesting, but we need to continue with the program.
Yeah.
So,
but you experimented in Buenos Aires in a few years. Okay.
We wish. Yeah. We hope with that, Vanessa, we will do in Buenos Aires.
Hopefully.
Okay.
Nice seeing you. Have a great day. Thank you very much.
Bye.
Bye. Thank you. Okay. So we continue with the program. Vamos a continuar con el programa. Le pedimos al doctor Pedran Rabasi, que es jefe del Departamento de Medicina del Memorial Sloan Kettering Center de Nueva York, quien va a dar la próxima charla. Y la moderadora va a ser la doctora Juliana Bill, médica oncóloga clínica del Hospital Israelí.
Thank you so much for the invitation. I'd be delighted to talk about a little bit about ctDNA. There's been much more advancements, many advancements in the past few months. I'm just going to focus on a couple of stories that I think are relevant, both for clinical practice and also for clinical trial design. These are my disclosures. So as you know, we've been utilizing liquid biopsy in clinic now in almost every aspect of clinical care. We started with metastatic disease, with genotyping the patients, more monitoring, understanding the resistance mechanism, so on and so forth, and have been developing assays for identification of minimal residual disease and microscopic disease. And also assays are being developed for screening that I'm not going to touch base on. But in the beginning of the talk, I will mainly focus on early stage breast cancer and some of the advancements that happened actually relatively recently in ctDNA world. So the challenge of ctDNA, as you know, it's that it's highly, highly variable. The amount of ctDNA can change extremely rapidly because the half-life of a ctDNA is essentially minutes to hours. So with an effective treatment, it can go down, initially goes up after it starts, killing the cancer cells and starts going down. And this dynamic range can be highly, highly variable, even in metastatic disease. And in early stage, because the amount of disease is limited, the amount of ctDNA in the blood can be extremely low. I'm just showing here graphically, the amount of ctDNA in one tube of blood can be less than 1% of a DNA of one cancer cell. And that's one part equivalent somehow to 1 part per million. And identifying ctDNA when we have less than 1% of a DNA from one cancer cell is an extreme challenge. And that's the type of range that sometimes in breast cancer we need to go. And I'm going to show you some of the data based on this. So there's been a lot of development in the MRD space, how to design assays. There are two major type of assays being developed in this space. One of them are based on bespoke assays. These are personalized assays. The tumor undergoes whole exome or whole genome sequencing, and a panel is specific to that type of cancer, and that patient is being developed, and either different ways of analyses, ddPCR, next-gen sequencing, even tumor-informed whole genome sequencing can be utilized to identify evidence of tumor DNA in the blood. And also there are tumor-naive methods, mainly based on epigenomic and methylation patterns, but there are also assays being developed based on fragment size and copy number size that can be utilized. Generally, the treatment-naive samples have a slightly lower detection rate compared to the bespoke assays, especially the modern bespoke assays, as you can see here on the right-hand side, based on schematic of the limits of detection for these tumors. So at MSK, we've been running MSK Link studies since 2015. As you can see, we have been collecting blood samples in the neoadjuvant setting and also in the patients who undergo surgery in the adjuvant, pre-op, post-op setting from all the patients. And we have started analyzing this data. We have now more than 2,000 patients included in the early stage part of the MSK Link, with many thousands of blood samples, unique blood samples collected. The data is becoming mature, and it's time for us to analyze them. And we have some data to show, and I'm going to share some of the data we recently reported at ESMO, and also we will update the results at San Antonio. So one assay that we are looking at is called Phase-seq. It's an assay developed by Max Dean and Ash Alizadeh at Stanford. The assay tries to decrease the amount of background noise by looking at very specific patterns of mutations. That is when two mutations are within the same fragment of a DNA. And ctDNA fragments are relatively very small, around 146 to 166 base pairs. So we are talking about small fragments of DNA. And then when the two mutations are next to each other, one of them can be identified by chance. There is sequencing error, there is PCR error, there's reading error, so on and so forth. But two of them exactly on the same fragment, if they are, the chances of them being called in error is extremely small. So by doing that, they increased significantly the specificity and also sensitivity of the assay. So I'm going to show you some of the recent data in breast cancer. So the workflow is similar to all the other whole genome-based bespoke assays. So the assay tumor undergoes a normal, from buffy coat will undergo whole genome sequencing. A custom assay is developed, specific alterations. In this particular assay, up to 5,000 targets will be included in the assay. The phase variants, those variants are on the same fragment, are being prioritized. And beyond the phase variants, normal variants, SNPs, indels, so on and so forth, will be also included in the assay. And then cell-free DNA will undergo ultra-deep sequencing using this particular panel of genes, 5,000 mutations, and the mutation calling will happen. So theoretically, and also in the analytical analyses, this assay could have reached less than 1 part per million. Actually, they showed that this can go to 0.3, less than 1 part per million. And I'm going to show you some of the data because I think it was interesting. I saw this data first and I thought, okay, this is This is theoretical and also in very controlled environment. But actually in clinical setting, we've been able to reach less than 1 part per million. So these are the initial data that we presented at ESMO. There is more data. We are updating this to 150 patients, and I hope to be able to present it at San Antonio. But as you can see, we've been able to assess the amount of ctDNA. These are baseline pre-treatment samples in all patients by subtype, by stage, by tumor size, by nodal status. And we've been able to identify patterns that the higher grade tumors have a higher ctDNA, nodal status is associated with higher levels of ctDNA. As expected, triple negative and HER2 positive breast cancers have a higher level of ctDNA at baseline compared to ER positive tumors, so on and so forth. But I would like to highlight that, this is 10-4 is usually where the current assays are. And if you look at that line, you see as many of these samples at baseline would have not been detectable using the assays that go to that type of range. So the higher sensitivity, higher limit of detection in this assay allow us to identify evidence of ctDNA at baseline at a different level, something that would have been called not detectable with the previous assays. More importantly, when we start looking at the patterns of ctDNA pre and post treatment, neoadjuvant, surgery, and also adjuvant therapy, we are identifying very interesting patterns. So in the analysis that was done in the I-SPY 2, there was a very clear indication that many of the patients actually cleared their ctDNA on neoadjuvant chemotherapy, but there were a group of patients that cleared, but they actually started to have progression and recurrence of the disease. So meaning that, if you look at this, many of these samples actually have ctDNA levels in 1 to 10 parts per million, meaning that a higher sensitivity assay will be identifying these cancers. These are these lines here, these cases here, will be identifying this much more accurately. In some of them, actually, it went below 1 part per million. I'm just showing here this case of a triple negative breast cancer who received neoadjuvant chemotherapy. You see that there was a significant drop in ctDNA from 0.1% to 1 part, less than 1 part per million. There was some fluctuation. The ctDNA never cleared. These are all were supposed to be not detectable using first generation or second generation assays. And you see that this patient ultimately, while receiving adjuvant chemotherapy with capecitabine, actually developed recurrence of disease, meaning that we are now able to monitor ctDNA dynamics much more accurately using this type of assays. And then it allows, I'm just showing you the full cohort. There was significant amount of dynamics in the ctDNA, but essentially when we start looking at this, there is a group of patients who at baseline, they did not have any ctDNA detectable. And also they remained negative throughout the therapies. These patients, essentially none of them had recurrence. I think it talks to the biology of the disease. There is a group of patients are not aggressive, or they do not have metastatic capabilities, and there is not much of a shedding of ctDNA from those tumors. These tumors have favorable outcomes. I think this is an important part, because in the previous assays, we always assumed, and it was correct if you remember the previous data, that this is probably because of the limits of detection of assay. With this assay, we've been able to go to less than 1 part per million. There is still a group of patients who are not detectable. So I think this talks about the biology of the disease. Now we can actually interpret these results, looking at the biology, identify these patients with favorable outcomes at the beginning. Then there's a group of patients who cleared it in the post-op setting, in the landmark post-op. If the patients in one single time point, if they were ctDNA negative, you see that they have also very favorable outcomes. And also the patients who cleared the ctDNA, they were positive post-op, and they cleared it with the adjuvant therapy. All of them did well, but the ones that they didn't clear their ctDNA on adjuvant therapy, essentially all of them had recurrence of disease. So I think for the first time, we start looking at the dynamics at the levels that we have not been able to in the previous studies. Nick Turner groups also analyzed the previously published data by their group using a different assay that also can go to the 1 to 10 part per million type of range. They presented data in ASCO, and they also showed a similar thing that these assays result in significant improvement of the detection rate across the cohort with high sensitivity and specificity, and is shown here in an example case, results in a better limits of detection and better lead time to identify ctDNA positivity, allow us, in this post-op setting here, you can see, allow us to do interventional studies more accurately. So I think I'm just going to show you, we are now thinking about different types of designs, how we're going to use this information in clinic and how we can identify, how we can utilize this. And I think there are potentials. So think about the patients who have no ctDNA detectability and think about the patients who are MRD positive. If not detection of ctDNA is associated with better outcome, we can think about de-escalated systemic therapy for these patients. So the patients who are negative can go to the de-escalated systemic therapy, and the patients who are positive, they can go and get escalated therapy. Even we can have MRD eradication as an outcome. The patient is not, this tumor is not sensitive to anthracyclines, but sensitive to Taxol, sensitive to other chemotherapies. We can actually identify, we can identify the response and adjust our treatment based on the response that we see in ctDNA, and also try to go all the way to eradicate with crossovers, bringing novel therapies to this type of setting, bring new ADCs to this type of setting, and try to eradicate the disease in the adjuvant or neoadjuvant setting. I'm just showing here the adjuvant, schematic adjuvant design. This is not a final design of the study. In the next half of this of the talk, I will focus on the metastatic disease and some of the advancements that have happened and some of my thoughts about how we can move the field forward in the metastatic setting using ctDNA. And as you know, we've been using liquid biopsy very, routinely in the metastatic setting. I show you here the ctDNA analysis using our internal assay MSK Access compared to our tissue assay MSK Impact at MSK. And you see that, ctDNA is able to identify actionable alterations accurately. More importantly, certain alterations such as ESR1 mutations, so on and so forth, are better actually identified in ctDNA, as has been reported. And some of the alterations are underreported in ctDNA as well, because structural variants, homozygous deletion, so on and so forth, are generally harder to identify in ctDNA than tumors. So I think there is a combination of these two would be the way that we move forward. But ctDNA is essentially a big part of the practice in metastatic setting. But can we use also ctDNA to monitor disease burden and go above and beyond just identifying actionable alterations? So the idea is that this is what we do. At this point, the patients have clinical progression or radiographic progression. At the time of progression, we genotype the patient, we identify the clones that have expanded, mechanisms of resistance, and then that guide us and inform us with the next line treatment. But can we go above and beyond and monitor the patients throughout treatment, identify the mechanism of resistance, and act on the resistance mechanism as these mechanisms are identified? We use the assays that are generally for genotyping. These are panel testing that are available widely in institutions and also in industry, and then identify, or ddPCR, so on and so forth, to identify these mechanisms of resistance. And a good example of it is such designs. The patient receives standard of care. The patient will be monitored routinely with ctDNA. If the actionable resistance mechanism is identified, then the patients can be randomized to continue standard of care versus escalation of care acting on that mechanism of resistance. And the patients who do not identify actionable resistance mechanism will continue the standard of care. And these patients will be followed by PFS1 and PFS2. So a good example of this is as you know, is the study that was done by Francois Clément-Bidard. This PADA-1 trial, proof of concept, showing that the patients who are receiving first-line AI and palbociclib, if they develop ESR1 mutations and the backbone endocrine therapy will be escalated to fulvestrant compared to an AI, they have a better outcomes both in PFS1 and PFS2. But can we go above and beyond genotyping? So as I just showed, we can go to the limits of detection far below what is available in genotyping, which is generally around 0.1%, maybe 0.05%. But can we go to the MRD levels of detection, something that actually is needed in metastatic disease, and identify these patients better and monitor the disease progression far earlier than what we could have done with imaging or also with genotyping, and try to act on those mechanisms of resistance when the clone is small, when the amount of heterogeneity and diversity is small. So one example of it is the data that was presented by Dave Siskin at ASCO recently. He showed that they followed the patients who were receiving first-line CDK4/6 inhibitor plus endocrine therapy with serial analysis with an MRD assay that goes to the detection rate of 0.01% to 0.005%. And they showed that they ctDNA in almost all the cases identified the progression earlier than imaging. There was no significant discordance between the two, and the lead time was significant, potentially allowing for earlier intervention in this setting. I'm just going to show you some of the examples of how we can utilize this type of ctDNA analysis. And these are just examples. This needs to be replicated in clinical trials, so on and so forth. But just showing you some of the examples, how this can be utilized in the setting, giving us some ideas how to utilize this type of assays better in clinic and also in clinical trial design. So this is a patient with high-risk germline BRCA1 carrier, high-risk ER-positive disease, received neoadjuvant chemotherapy, had residual disease, and then she went on Natalie clinical trial. At the time, Olympia clinical trial was closed at the time. So she came back a couple of years later with a solitary brain met and also a solitary liver met. The brain met was resected and radiated, and we put her on first-line olaparib. And she had a fantastic response, essentially complete response on imaging. Because I did not have much to follow, I started following these patients with ctDNA MRD assay. And at some point, her ctDNA started to become detectable. Imaging did not show any evidence of disease in the liver or anywhere else. But considering the amount of ctDNA, and this is just 0.04 mutant molecules per milliliter, I did an MRI of the liver, and we've identified a 4-millimeter lesion that at the site of the previous lesion, that there are radiologists seem to have viable disease. This patient received SBRT to the liver, resulted in the decline in ctDNA, and she remained on olaparib for another 1 year. She started to have increase in ctDNA. Again, systemic imaging was negative. But when she had some neuropathy, we did CNS imaging, and she had bulky leptomeningeal disease. She received Proton CSI. We put a Ommaya in her. We started collecting the CTCs and also ctDNA from the CSF, allowing us to show that this tumor actually was resistant to Proton CSI. The CTCs started to go up significantly weeks after the Proton CSI. So she received intrathecal topotecan, and that was last year. So since last year, she has been systemically NED, and she has had no CTCs in the CSF and is doing well on a TDXD at this point. So this is another example of a patient with high-risk triple-negative breast cancer who came again with a solitary brain met, no systemic disease at the time of diagnosis. Then ctDNA actually showed some increase in the levels of the in the blood, prompting us to repeat imaging, and we identified the solitary liver met, which in the CT scan actually appear to be more lesions adjacent to that solitary liver met. We biopsied it. I would like to show that there was a significant increase in the ctDNA when we biopsied the tumor. And then considering the type of treatments that she received, that she was still on some treatment when she had the progression, we put her on first-line T-DXd. And what happened was that on the third scan on first-line T-DXd, the patient had massive progression of disease. You see here, there is a progression of disease both per imaging and also based on PET scan. There was a significant increase. But what was interesting was the discordance between the imaging and ctDNA. As I show here, ctDNA showed a significant decline in ctDNA exactly the same time as we saw the progression of disease in the PET scan. That prompted us to think maybe this is evidence of pseudo-progression, and this tumor actually is having a major immune response. I actually encourage the patient to have a biopsy to prove this. The patient declined, and she travels from another state to come to see us in New York. But we continued following the patient with serial imaging and ctDNA, and a short interval CT and PET scan showed clearance of the FDG avidity. This patient now is ctDNA not detectable, and the lesion is less than point something centimeter, and potentially not even viable. So again, an example that ctDNA monitoring can, in some cases, be superior. And many of these cases, and we don't know how many actually, that the patient had a clear progression, clinical progression, could have had an immune response that completely missed. This could have had happened with naked chemotherapy or other types of chemo treatment as well. So I think considering these, there is we need to obviously do clinical trials to show that this is a viable path. But considering this, we can design such clinical trials that the patients with oligometastatic disease receive local therapy such as SBRT or ablations, cryoablations, so on and so forth. If the ctDNA gets cleared, the patient continues the standard of care or receive de-escalative care. But if the patient's ctDNA does not clear, that means that there are other sites of disease, or there was a resistant disease at the site that received ablation, and this patient should receive escalated systemic therapy. And this will allow us to identify patients better for oligo treatment, and also, about the data from the oligo SBRT studies that in breast cancer were negative. I think part of it is because of misunderstanding nature of oligo in breast cancer, and many of these patients potentially had microscopic disease in other sites, so they never cleared the ctDNA with SBRT. So these are the type of trials that we can think about if we consider the ctDNA monitoring in this space. The patients can go and get randomized to receive standard of care imaging, but ctDNA will be collected but not reported to the patients, or in the beginning will be reported to patients. And then also the patients can go on the ctDNA monitoring only, and imaging will be done when the ctDNA starts to show increase or progression of disease. So this will be a ctDNA triggered imaging type of study that this is not a final design. There are a lot of tweaks that we can do in this, but considering the nature of breast cancer, lobular breast cancer, the bone-only disease, unmeasurable disease, patient with stage 4 NED disease, patients with oligometastatic disease, I think there are a lot of potentials. And also, as I showed, potential pseudoprogressions. There are potential scenarios that ctDNA can be superior to imaging in this setting as well. And we can go above and beyond. We can go and try to eradicate ctDNA in a group of patients for whom we have good amount of highly effective disease and good amount of data showing that there are long-term responses. And for that, the obvious choice for us was HER2 positive disease. So we started thinking about, can we utilize these ultrasensitive ctDNA assays, adaptive escalation and de-escalation paradigms that we've been using very effectively in the post-neoadjuvant setting in breast cancer, and try to go for a curative intent approach in metastatic breast cancer and try to eradicate the ctDNA and not just treat the patients for imaging. So the obvious choice was HER2 positive disease, metastatic HER2 positive disease. We put a team together, and we've been thinking about this design for more than 2 years. We came up with some principles utilizing the sequential therapy, treat the patients to molecular complete response and complete response by imaging, utilize local therapies as needed, put CNS prophylaxis in the front and center of the study. We know a lot of these patients with HER2-positive disease will recur in the brain, and also try to monitor the patients with the based on molecular complete response. So this is a very simplified version of the assay. We try to borrow from our colleagues in the hematologic malignancies that we have been able to cure many of the very aggressive cancers, ALL, AML, so on and so forth. They go and transplant a patient with evidence of molecular residual disease. So we will go for an induction that puts a lot of our good treatments in use. If the patient does not have a complete response, both by imaging and molecularly, this patient will go to the second induction, try to eradicate the disease. Local therapy will be also applied. The patients will be treated in the paradigm of neoadjuvant treatment. The patients, these are de novo metastatic breast cancers that will be included. All of them will have breast surgery as well. And then we put the patients on consolidation with a CNS penetrating agent. And the patients after that will be monitored essentially just for the endpoint of complete response, stopping all treatments. If the patient can maintain both molecular complete response and complete response throughout the course, we will also get a lot of CNS imaging, and also the patients undergo LPs for CSF analyses, both with CTCs and ctDNA. We think this type of design potentially allow us to go and use our best treatments, try to see if it's possible now. We've tried this before and it was not successful, but do we have much better treatments at this point? Is it possible for us to induce long-term remissions in a group of patients, potentially cure a subset of metastatic breast cancers? And we understand there is a group of patients that will not be cured, and we would like to learn who are those patients. So we will have a very heavy correlative work. We make PDX cell lines, from these patients. We have whole genome, transcriptome, single cell analyses included in this design. Try to understand who are the patients who will not be able to eradicate it. Their tumor, it will not be able to eradicate it. Try to identify them, design better studies and better treatment paradigms for them. So with that, I would like to thank you for the opportunity, and I'm ready if you have any questions. Thank you.
Thank you, Dr. Razavi, for this brilliant presentation. I would like firstly to thank everyone here from the organizing committee for inviting us to discuss this amazing topic. That was a brilliant presentation, and seeing that we can use that in a clinical trial and actually implement what we are learning from in the daily basis and benefiting a patient. I think that's what's the most important thing. And I would like to ask you just one very quick question. Every single time we are doing clinic here, at least in Brazil, people come here and they ask, when are you ready yet to use ctDNA in practice? I'm not really sure we can use it outside a clinical trial. And regarding all the clinical trials for early breast cancer and also for metastatic breast cancer, I would like to ask you, in which scenario do you think ctDNA will be implemented first? Because for drug development, we know that people tend to study it before in metastatic cancer, and then they come to the early setting. But I'm kind of like feeling that maybe for early breast cancer, for PET-CR and things like that, maybe ctDNA will become available before then the metastatic scenario.
Yeah, so I should say I'm actually very conservative in clinical practice in early stage. I do not offer this routinely. I know some of our colleagues in the US offer ctDNA monitoring routinely to all the patients in early stage disease, but I actually do not. I think the data at this point is immature. We do not understand the full extent of negative predictive value for these assays. The third generation of assays have not entered clinic, and we don't know the data for those as well. And there have not been large scale studies showing the negative predictive value, positive predictive value of those assays. Well, so I actually very rarely use ctDNA monitoring in early stage disease. In metastatic disease, obviously, we use ctDNA heavily, both for genotyping and for monitoring. I should say there are certain scenarios that I have used it. The patient is reluctant, for example, to receive any adjuvant therapy, declines, treatment. I use this as a leverage and also give me some confidence to monitor the patient who is refusing standard of care. I have an option to escalate. So I will give the patient standard of care if ctDNA comes back positive. But the problem is that many of our colleagues, monitor the patients. There are false positive results, especially in low-risk patients. There are false positive results. Then no one knows what to do with those false positives. A lot of anxiety for the patients. Not common, but the false positive rate very much depends on the baseline risk of the patient. If the baseline risk of the patient is low, the relative risk of false positives is actually relatively high. So I think those type of scenarios cause a lot of anxiety. And also there are true positives with negative, imaging. The patient is not metastatic. What should we do with those patients? So part of our practice at MSK is to see these patients coming from community, coming from other centers who are ctDNA positive, to ask us what should we do, and the answer is that there is no data, and then and there is a significant amount of anxiety for the patients. We try to be innovative. If there is a standard option, so there is a creative options for those patients. So in reality, it's being used, but I actually do not use it, and I don't think that they are primed to be used in early stage out of clinical trial. That being said, we have our MSK Link study. We try to collect blood samples from every single patient who comes to MSK. We monitor them regularly. We collect blood samples from them regularly. And we started to learn what are these dynamics and how we can use it. So I think we are still in the learning space, and it's time for us to do definitive clinical trials like the ones that have been done in colorectal cancer in this space. It's a long answer, but I hope that it was clear where I stand with this.
It is, but it's a very interesting topic. That's why it's a long answer.
Yeah.
Thank you very much.
Thank you. Thank you very much for both. We need to
Thank you.
contribute the program. Thank you. Cari.
Vamos a continuar con la siguiente conferencia, que por un problema personal del doctor Mark Robson va a ser una conferencia grabada sobre manejo de pacientes BRCA positiva en prevención y tratamiento. Posterior a la visualización de la conferencia del doctor Mark Robson, va a hacer las preguntas, un comentario sobre la conferencia el doctor Gil Deza.
So, good morning. I am sorry that I can't be there in person. I'm afraid I had a family emergency, and that's going to take up my Saturday morning. So thank you for allowing me to record this. I'm going to spend a little bit of time just reviewing where we are with hereditary breast cancer. And I think I always start my talk with this because I think it's interesting to review what we thought when we were beginning all of this. And we thought that high penetrance mutations like BRCA1 were rare. We thought that we could identify them with pedigree analysis. In other words, you could recognize the autosomal dominant predisposition and find the people who had mutations. We thought that people who had mutations were essentially destined to develop cancer, either breast or ovary. And because of that, and because of the uncertain benefit of preventive interventions, we were very sensitive to the potential psychological and societal risks of genetic testing. And importantly, and perhaps what we're going to spend most of the time talking about today, is we didn't have a concept of how the information could be therapeutically relevant. Now, of course, the first steps towards understanding therapeutic relevance were in the preventive surgery side, where there were studies demonstrating that prophylactic mastectomy does indeed prevent breast cancer, and that risk-reducing salpingo-oophorectomy at least decreases the risk of what at the time was thought to be largely ovarian cancer, but of course now we recognize as being both fallopian tube and ovarian cancer. And the uncertainty is reflected in the fact that people were getting New England Journal papers for demonstrating that this was actually indeed the case. But certainly the first therapeutic implications of genetic testing were related to preventive surgical interventions. Now, the problem with surgical prevention, of course, is that not everybody does get a breast cancer, and not everybody does get an ovarian cancer. So when you look at cumulative lifetime risks for breast, it's about 65 to 70% for both BRCA1 and BRCA2. And of course, the ovarian cancer risks are different. They're over 40% for BRCA1 and roughly 20% for BRCA2. So what this means is that if everybody undergoes surgical prevention, certainly on the breast side, nearly 30% of people are going to be undergoing that procedure unnecessarily because they never would have developed a breast cancer. And this is clearly problematic. There is no other situation that I can think of in medicine where we would offer somebody a procedure that was that impactful, and 30% of the time it was unnecessary. Of course, subpinguoophorectomy is a little bit less problematic because it's internal and women are going to go through menopause anyway. But certainly early menopause related to subpinguoophorectomy is a major hit and a major quality of life issue, and potentially could have long-term health effects. So surgical prevention, although it's become very accepted for particularly BRCA1 and BRCA2, it's not without its challenges, without its issues. We've been struggling to find non-surgical prevention for years and really have not come up with much so far. This is an idea that initially was generated from some lab data from Jeff Lindemann's lab down in Australia, in Melbourne. And what they recognized was that rank ligand signaling was associated with differentiation of a abnormal luminal progenitor cell that was hormone receptor negative into basal-like tumors. And so naturally, denosumab is a rank ligand inhibitor, antibody against rank ligand. And so the idea would be that if somehow we could inhibit that, we could prevent the abnormal differentiation. So there is a randomized trial that's underway looking at women who have germline BRCA1 mutations, since this appears to be a BRCA1 specific effect, randomizing them to either denosumab or placebo, with the idea being that the endpoint of breast cancer occurrence. This was needing to be a huge trial, and so there's a tremendous collaboration, but unfortunately accrual is not proceeding as we would like, so we may not get the answer to this question. Other approaches to non-surgical prevention are things like vaccination. None of that seems to be at least ready for prime time or even actually ready for a definitive clinical trial. So even though surgery is not ideal, it's kind of what we got. Of course, the other approach would be not true prevention, but just early detection. And there's a lot of work going on with circulating tumor DNA now to try to identify minimal residual disease. Certainly the available assays are inadequately sensitive, even the commercial ones. And one of the problems with the more sensitive assays is that they have to be tumor informed. In other words, they're using the mutational pattern in the tumor in order to find it. At least that's with genomic sequencing. There are other approaches like fragmentomics and looking for methylation patterns. And certainly proteomics is coming along. And ultimately, we may wind up needing to do a multi-omic type of approach. This is something that we've been working on, which is kind of interesting, is that in tumors with BRCA alterations are highly aneuploid because of the genomic instability. And whole genome sequencing is becoming cheaper. And so in theory, one could do relatively deep whole genome sequencing on circulating tumor DNA and detect just simple allelic imbalance as a marker of tumor burden. And perhaps this would be a way of doing early detection. This is Adam Widman from our group who's been working on this with support of the Breast Cancer Research Foundation. And at least in terms of proof of principle, these are 3 cases of individuals who are receiving neoadjuvant therapy and undergoing surgery. And what you can see is he has been, in a tumor agnostic way, able to determine or able to demonstrate a decrease in circulating tumor DNA as one would expect, related to preoperative therapy and indeed to surgery. So at least in concept, this could work. Now, it's not all BRCA1 and BRCA2, of course. There's been a lot of work that's been done in defining the genetic architecture of breast cancer risk over the years. Certainly the rare high penetrance variants like BRCA1, BRCA2, et cetera, have captured most of the attention, but there are also moderate penetrance variants such as those in CHEK2 and ATM, which are not uncommon. And then, of course, a whole bunch of individual loci, single nucleotide polymorphisms, common variants that were identified through genome-wide association studies. And those have not yet entered the clinic, although people are now looking more and more at polygenic risk scores as a potential way of defining risk. Now, these are just illustrations of the, or at least a significant proportion of the single nucleotide polymorphisms or SNPs that are associated with breast cancer risk. There's about 300, there are thousands, but the canonical PRS is based on about 313. And what you can see is that for all of these, the odds ratios are actually relatively low. But when you combine the genotypes in each one of these different loci, you can sometimes accumulate a relatively high relative risk or relatively high odds ratio. If someone is unfortunate enough to have the high risk form of 300 of the 313 alleles, which is theoretically possible, then they may have a meaningful increased risk, even in the absence of a family history or other factors. PRS is an individual risk assessment, has not really gotten into the clinic yet. Some of the commercial laboratories are trying to use it, but unfortunately, for those people who are at either the higher or the lower end of the scale, sometimes there's a little bit of difficulty truly believing it, since it's not necessarily reflected in family history, although it's probably true. But one thing that may be more useful is that polygenic risk does modify the risk of moderate penetrance genes like ATM and CHEK2. It actually modifies the risk of all the predisposing genes. But for BRCA1, BRCA2, and PALB2, for instance, the PRS modification is not strong enough to impact clinical recommendations. However, for CHEK2, ATM, BARD1, and the other moderate penetrance genes, whether you have a high or a low PRS may significantly impact whether you're at risk at all. So what you can see here, this is a study done by the NCI group, NIH group. And what you can see is that if you start incorporating PRS and family history, you can define people who, as a matter of fact, are not even at the 20% lifetime risk that is the US threshold for MRI screening. And so, for instance, in BARD1, if you don't have a family history, you have a BARD1 mutation, and you are able to use PRS, you can define a subset of 70% of those patients who are not even at increased risk. Then for ATM, if you have an ATM variant, no family history, and you're able to incorporate PRS, 50% of those people are not at increased risk. So moderate penetrance predisposition certainly needs to be handled differently than high penetrance predisposition, and particularly when it comes to discussions of surgery, because many of these women are not at increased risk at all. And it gets even more complicated because if you start incorporating other factors besides PRS, like traditional reproductive risk factors and mammographic density, the spread of risk becomes even greater. So what I'll show you here is that the blue curve is the distribution of risk in a CHEK2 carrier, either without a family history or with a family history, once you incorporate all of her factors. The red line here, the purple line, is the risk associated with breast cancer in the general population. And what you can see is that if a CHEK2 carrier has no family history, a meaningful proportion of those women are not at increased risk, and not even at the 20% threshold. And some of those women are not even at population risk. And even with a family history, there's a small proportion of women who are not at population risk, and a bigger population that's not even at 20% risk, just as I showed you in the previous slide. So I think the take-home message here is that not all genetic predisposition is the same, and moderate penetrance predisposition needs to be managed much more skeptically, I guess, than high penetrance predisposition. Now, the other area where there's been a big advance, of course, is in treatment. This all started in the early aughts with the demonstration that PARP inhibition could cause cell death in the setting of BRCA deficiency, either BRCA1 or BRCA2. The two canonical papers were in Nature. And then the biggest advantage to PARP inhibition was demonstrated in ovarian cancer. This is the SOLO-1 trial using PARP maintenance after olaparib maintenance after carbotaxol induction. And you can see a dramatic improvement in progression-free survival and eventually overall survival compared to placebo. Breast studies have really not been that impressive. These are trials in first-line metastatic therapy, and as you know, the improvement in progression-free survival was about 3 months, maybe a little bit less, with no improvement in overall survival in either the olaparib or the talazoparib study, although significantly improved response rates compared to physician's choice chemotherapy. So this definitely does work, and there are some people who have prolonged responses. It's a relatively small number, but prolonged responses. There's a number of reasons why the breast studies might not be quite as impressive as the ovarian studies. Don't really have time to go into that in detail, but nonetheless, it is what it is. The real reason for this is because of resistance. And while primary resistance is not that common in untreated patients, the development of resistance can occur very quickly, and it occurs through a number of different mechanisms, one of which is so-called reversion. So what happens because of the genomic instability is that essentially you have a million monkeys jumping up and down on typewriters, and in some of those outputs, you wind up with splicing out, if you will, of the germline variant, not you have loss of heterozygosity of the originally wild type allele, but the germline variant gets spliced in such a way that the open reading frame is reestablished. And this can happen in multiple different sites with multiple different reversions. This is sort of conversion evolution towards resistance. This was demonstrated by our group in circulating tumor DNA, but it can certainly be shown in multiple biopsies from different sites. But anyway, the reestablishment of a little bit of BRCA function is enough to have enough homologous recombination that repair that the PARP inhibitors don't work anymore. There are a number of other mechanisms. This is work that was done by Andrew Tutt's group, and showing that basically at baseline, very few people had resistance mechanisms identified. There was a group of patients who eventually wound up being primarily resistant, who did have changes at baseline. But then at the time of resistance, the most common mechanism of reversion was, the common mechanism of resistance was indeed reversion. There were some other mechanisms by which homologous recombination can be restored. Don't really have time to go into those, but reversion is clearly the most common. And importantly, the most common sites for this reversion are sites of microhomology. And this is because when there are double-strand breaks at regions of microhomology, there is an alternative mechanism by which the double-strand break can be repaired, called alternative end joining, where things are just basically stuck together. And if that happens at a region of microhomology, you can restore the reading frame. Now, interestingly, the main enzyme that's involved in this, or one of the critical enzymes that's involved in alternative end joining, is an enzyme called Pol theta. And it turns out that there are actually drugs that can hit that. And so certainly single agent therapy doesn't seem to work particularly well, probably because there are other mechanisms at work by that time. And so you're no longer, once the cells have restored homologous recombination proficiency, they're not as dependent upon alternative end joining. So that doesn't really help. But an idea would be that since the resistance reversions are dependent upon alternative end joining, if we inhibited this, could we potentially prolong the time before resistance develops? And there is some work both preclinical work done that suggests that this may be the case, and indeed, in collaboration with Gaurav Gupta from the UNC, we're developing a trial for the TBCRC, trying to look at this question of olaparib versus olaparib plus a Pol theta inhibitor to see whether or not we can improve the durations of response. Of course, the other side of this is now extending PARP inhibitors to other patient populations. The one that seems to be benefiting the most are patients who have germline PALB2 alterations. It is not working particularly well for patients who have ATM or CHEK2 mutations because those patients are not truly homologous recombination deficient per se. It does seem to work quite well for patients who have somatic BRCA1 and BRCA2 alterations, although that is a complicated story because of the issue of allele frequency and loss of heterozygosity. But nonetheless, in this particular trial, there was a meaningful response rate. Just to illustrate why it doesn't work for ATM and CHEK2, this is where BRCA1, BRCA2, and PALB2 operate, which is all the way down at the effector portion, if you will, of homologous recombination, while it turned, and so all three of these are very, very sensitive, but ATM and CHEK2, BARD1, they're all upstream of that process. They're essentially acting as sensors and preparers, if you will. And so when you look at signatures of homologous recombination deficiency, you generally don't see them in tumors that are associated with ATM or CHEK2. And therefore, it makes sense that the PARP inhibitors aren't going to work in that setting. They're just at a different part of the DNA repair cascade. So not all DNA damage repair is the same, and it's important to bear that in mind. Lastly, the question comes up is, could this potentially work in a group of patients who are wild type for BRCA? This is a randomized trial done in patients who have triple negative breast cancer, who receive gem-carbo induction, and then if they have either a response or stable disease, randomize them to continue olaparib pembro or just gem-carbo pembro. And what you can see is that no, the olaparib pembro doesn't help. It's not better than carbo gem pembro, but it's not worse. And it may actually even be a little bit better in the patients who have BRCA mutations. So there is a subset of patients who have sufficient homologous recombination deficiency that they can at least be maintained on PARP inhibitors. But this is probably not going to become a clinical approach, and it's certainly not going to become a label for olaparib. And then finally, there are new drugs coming into the PARP1 selective. It turns out that most of the toxicity related to PARP inhibitors is due to PARP2 inhibition. And so there are PARP1 selective drugs such as saruparib, in which this is data that was presented at AACR showing meaningful response rates. Toxicity, unfortunately, does not appear to be dramatically different, but nonetheless, it certainly is a new agent, and there's hope that it will be more potent and therefore might be able to have an impact in situations where first-generation PARP inhibitors do not. And lastly, the question comes up about the sequencing of PARP inhibitors versus standard of care. There are data now, both from our group and increasingly from others, showing that first-line PARP inhibitors are more effective than later, and also that there is a potential for resistance to the traditional CDK4/6 inhibitors, or at least early development of CDK4/6 inhibitors in BRCA-deficient cells. And therefore, there's now a randomized trial that's being led by Pedram Razavi of our group, combining saruparib, first-generation PARP inhibitor, with a SERD, comparing that to standard of care endocrine therapy or a CDK4/6 inhibitor plus the SERD, looking for whether or not there's actually an improvement in progression-free survival. So the take-homes from this are that 30 years on, inherited susceptibility is still a big problem. It's hard to predict, risk in a meaningful way. We don't have effective non-surgical prevention, and our targeted therapy is limited by the quick development of resistance. But we do have opportunities for early detection. Earlier use of PARP inhibitors like adjuvant therapy offers opportunities to improve outcomes, and maybe in combination with other drugs to extend their effectiveness. ctDNA-guided follow-up might offer us an opportunity to intercept metastatic disease. And of course, newer agents are on board, or we're working for newer agents to improve the delay of development of resistance or improve tolerability. So thank you very much for your attention. And I'm sorry that I'm not available to take questions. And again, I apologize for not being there.
Muchísimas gracias por la presentación que ha hecho el doctor Robson y esperamos que se resuelvan sus problemas familiares. Yo quería hacerles un comentario muy simple sobre tres aspectos que me parecen cruciales de estos 30 años de conocimiento sobre pacientes de alto riesgo genético. Uno está relacionado con que la medida preventiva más importante sigue siendo la cirugía y creo que desde ese punto de vista es clave recordar la conferencia del doctor Farante de la semana pasada sobre la posibilidad de preservar la inervación de la areola y el pezón conservando la perforante inferior anterior medial con su nervio y de esa manera lograr una cirugía efectiva y mejorar la calidad de vida de la paciente preservando la sensibilidad. Lo segundo es claramente la evidencia en estos 30 años de la seguridad de la terapia hormonal de reemplazo en las pacientes que han sido sometidas a salpingo o forectomía, si fueron histerectomizadas con estrógenos solos y si no fueron histerectomizadas con estrógenos y progesterona, porque eso claramente mejora la calidad de vida de las pacientes y es segura, sobre todo administrada a corto tiempo. Y el tercer punto que me parece importante rescatar de la charla de Robson es el eventual doble rol que puede jugar el denosumab, tanto en la quimioprevención impidiendo la progresión hacia el triple negativo por la inhibición del RANKL, como la seguridad y la mejor calidad ósea de las pacientes. Con lo cual, creo que independientemente de la baja tasa de incorporación de pacientes en el estudio randomizado, este subgrupo de pacientes debería ser observado como un grupo que probablemente se beneficie más con denosumab que con zoledronate para la prevención de la salud ósea. Estas tres cosas me parecen cruciales en la línea de optimizar el tratamiento de las pacientes de alto riesgo. Una cirugía que preserva el nervio y la sensibilidad de la areola y el pezón, la terapia hormonal de reemplazo para la extirpación quirúrgica profiláctica de los ovarios y el denosumab en la prevención de la salud ósea y eventualmente la quimioprevención en este subgrupo de pacientes. Muchas gracias, Karina, Darío y Gabriel.
Muchísimas gracias, doctor Ernesto.
Vamos a continuar y después te volvemos a ver, Ernesto, así que no te nos vayas.
Perfecto. Gracias, hermano.
Ok, vamos a continuar con la doctora Mónica Fournier, que es ella miembro asociada del Servicio de Medicina de Mama del Memorial Sloan Kettering Center y va a ser moderadora nuevamente la doctora Juliana Bell. Dr. Fournier, can you share your lecture?
Yes, absolutely. I couldn't share up until a few minutes ago, but here it is. Okay, thank you so much. Sorry for the technical glitch. And I'm going to just do a review about neoadjuvant therapy in breast cancer and what are the new things and how we treat patients in the different subsets. So neoadjuvant therapy is basically, as we all know, it is the use of systemic therapy as the first modality of treatment for primary breast cancer. So this is not a new strategy. It was actually introduced into clinical practice back in the 70s. And I think several years ago when I was at Gianni Bonadonna Institute in Milan, we had a lot of clinical trials and what was at that time called CP or chemioterapia primaria. And that was the use of neoadjuvant chemotherapy before the definitive surgical time. So historically, the primary scope has been to achieve operability for patients with locally advanced disease with positive lymph nodes. But in most recent years, it has been progressively utilized also in patients that are candidates for mastectomy to increase the chance for breast-conserving surgery and, as we'll see, also to select patients for certain disease subsets. Sorry, I cannot seem to. Okay. So this is basically the evolution of neoadjuvant chemotherapy. If you can see, in the past, in the 70s, 80s, it was mostly only for locally advanced disease to increase local control. But then it started to move into earlier stages to increase breast conservation. The possible endpoint later on was to potentially increase survival by utilizing a systemic approach sooner rather than later. And right now, most recently, it is utilized for treatment tailoring in different subset of disease. This is for chemotherapy. We also have endocrine therapy, which is not, however, not widely utilized. Generally, most often has been to treat elderly women that have other comorbidities, but also to increase breast conservation and for treatment tailoring. So these are the standard definitions. Basically, treatment is given before the time of surgery with therapeutic intent to downstage the disease and to determine the efficacy of a regimen against early breast cancer. And also we have pre-surgical biological window trials that are not neoadjuvant trials. However, they're completely different. This means a short course of an agent, a compound that is administered before surgery to basically test its activity either from a biological or pharmacodynamic, and it's a kind of an in vivo target rather than a therapeutic efficacy. And it's usually a few days, sometimes even one dose only, or a few weeks. And it's completely different from the neoadjuvant approach, which instead has a therapeutic intent. So neoadjuvant therapy, we're always talking about tailoring treatment and personalized care. Neoadjuvant therapy is personalized care because it might increase surgical options, the operability of locally advanced breast cancer, select patients for conservative surgery, patients that might have been mastectomy candidates, but also might convert positive lymph nodes into negative lymph nodes, allowing for a less aggressive axillary surgery. And actually for similar outcomes when compared to adjuvant systemic therapy. So the idea, I think, in the past was that perhaps by giving chemotherapy first before the surgical time, we could the idea was in the past that maybe we could improve the outcome of patient by giving systemic therapy prior to the surgical time. However, data has shown that when we are going to review this in a few slides, that what we're identifying are just the patients that are going to do better by this approach. But it's not necessarily that the fact of delivering systemic therapy prior to surgery is going to improve disease-free and overall survival. Okay, so these are the long-term outcomes for neoadjuvant versus adjuvant chemotherapy, and this is a meta-analysis from 10 randomized trial. And basically, you can see from this that the outcome in terms of disease-free survival, distant recurrence, and breast cancer mortality is actually similar, as I was saying before, between the neoadjuvant and adjuvant approach. In one study, there was a higher rate of local recurrence, which was, however, basically driven by trials allowing to avoid surgery in case of a complete clinical response. But in terms of distant recurrence and in terms of breast cancer mortality, the two approaches can have similar outcomes. So what is the definition of pathologic complete response, PCR? PCR is what it's basically has been used as a surrogate endpoint and is defined as the absence of any residual breast cancer on hematoxylin and eosin evaluation of the resected breast specimen and all sample ipsilateral lymph nodes following completion of systemic therapy. There is different definitions. Some allow the presence of in situ carcinoma, some do not, but it has been used to define the endpoint of clinical trials. So patients who attain a pathological complete response defined as YPT0 and 0 or residual ductal carcinoma in situ do have improved survival. However, about 10 years ago, Patricia Cortazar was at that time working for the FDA, performed a pool analysis that could not really validate pathological complete response as a surrogate endpoint for improved event-free and overall survival. So basically, PCR has a prognostic value. However, it is not that patients who achieve a PCR are going to have a better outcome because they're being selected by the response to systemic therapy. And again, this was published, and this is data from Minkovitz and colleague about the prognostic impact, basically, of complete response on disease-free survival in over 4,000 patients, according to breast cancer subtype. So you can see the difference between disease-free survival and for the different luminal A, luminal B, HER2 positive and triple negative. And this is Patricia Cortazar data showing the long-term outcome from the pool analysis from neoadjuvant treatment. So basically, yes, the patients who achieve a PCR are going to do better, but this is because the administration of systemic therapy prior to surgery is going to select those patients that are going to have a better outcome. Pathological complete response has been accepted as a surrogate of clinical benefit, and so several agents have been granted accelerated approval by the FDA because this is an endpoint that is reasonably likely to predict a clinical benefit in the neoadjuvant setting. So what are the indications for neoadjuvant treatment? In the past, as I mentioned, it was mostly for patients with locally advanced disease, such as inflammatory breast cancer, T4 and 2 or 3 disease. At this time, yes, still those patients with locally advanced disease, but also for patients who have lymph node positive clinically, and in order to avoid a more aggressive axillary surgery, such as an axillary lymph node dissection, patients who have an unfavorable tumor to breast ratio, meaning small breast and a large lesion, to avoid mastectomy, but also the majority of patients with triple negative and HER2 positive breast cancer, because it can select, as I said, the patients who are going to do better, and it therefore informs our prognosis and subsequent adjuvant indications, as we'll see. So neoadjuvant therapy is currently the standard for the majority of patients with stage 2B or stage 3. One should do a complete diagnostic workup, including cytology, of course, of suspicious axillary lymph nodes. We're going to take a look at what are the regimens utilized, but it's most frequently an anthracycline and a taxane-containing regimen for 6 to 8 courses. And there is, of course, immunotherapy for patients with triple-negative disease and HER2-targeted agents for patients with HER2-positive disease. Response, it is monitored with clinical exam, breast imaging at the completion of the systemic treatment plan. And of course, it's very important that there is a collaboration between the breast surgeon and the medical oncologist. And there, because of this reason, there's been an increasing use of neoadjuvant therapy. If we see from the beginning of the year 2000, from 2015, the proportion of patients with the different subset, especially patients with triple-negative breast cancer and HER2-positive breast cancer, that receive neoadjuvant therapy has markedly increased. So what are we doing to increase PCR rates, basically? For triple-negative breast cancer with standard chemotherapy, the rate of PCR was in the range of 30–40%. If you add the platinum-containing agents such as carbo or cisplatinum, it increases to about 50%. And now standard neoadjuvant therapy for triple-negative breast cancer is at the backbone with an anthracycline and a taxane-containing regimen, but also a platinum agent plus pembrolizumab as immunotherapy. For HER2 positive, you have standard chemotherapy plus a dual antibody targeting against HER2 with trastuzumab and pertuzumab that can achieve a rate of PCR close to 70%, so a very significant percentage. Less Less rates are achieved, of course, in patients with hormone receptor positive disease, in which we still utilize neoadjuvant therapy with standard chemotherapy, such as anthracycline and taxane-containing regimen. However, the rates of PCR are much smaller. What about the nodal positivity rate after neoadjuvant chemotherapy? Again, you see that patients with patients with N0, of course, they have lower nodal positivity rates after neoadjuvant chemotherapy compared to upfront surgery. Nodal PCR, and for patients with clinically node-positive disease, nodal PCR is achieved in approximately 40 to 70% of cases. And as I mentioned before, there's the potential for decreasing the extent of axillary surgery with sentinel lymph node sampling, so a less aggressive surgical approach. And if you see, the highest percentage of nodal PCR are achieved as regular PCR for patients with either triple negative or HER2 positive disease. So these are all the, just quickly, we're going through all the neoadjuvant study in the different breast cancer subsites, including HER2 positive, triple negative, and hormone receptor positive breast cancer, specifically luminal B. Targeting HER2, of course, has been a very successful story, and the availability of these monoclonal antibodies, such as Herceptin, trastuzumab, and pertuzumab, has dramatically changed the prognosis of HER2-positive breast cancer, both in the early and metastatic setting. And the phase 3 randomized trial established the role of these agents not only to improve survival for patients with stage 4 disease, but also to improve disease-free and overall survival for patients with early stage. And also, neoadjuvant trials have reported significant increase in PCR rate. We're not going to go through all the historical trials, of course, but just just a few, some of the older data. You see, this was a small study from Andy Anderson, just showing that if you added trastuzumab to standard conventional chemotherapy, you would basically triple the percentage of PCR from 26% to 65%. And this was, both for patients with hormone receptor positive and patients with hormone receptor negative disease and HER2 positive disease. The current approach involves dual antibody targeting. This is based on a number of trials from the past. Here we're showing the Neosphere that basically utilize the standard backbone of a taxane and anthracycline regimen, and also utilize trastuzumab and pertuzumab, and this cause a higher rates of PCR achieved with dual antibody targeting with both trastuzumab and pertuzumab. So again, this is the escalating strategy. In the beginning, patients were treated more in the adjuvant setting, but nowadays the vast majority of patients, these are all the different trials with HER2 positive breast cancer, are treated in the adjuvant setting if they have, if they don't have stage 1 disease, and therefore the best results in terms of PCR are achieved with the dual antibody targeting. So what is the management of this patient? Patient with a T1A and B and clinically node negative, they proceed to surgery and then receive adjuvant therapy. However, patients with larger tumor, clinical stage CT1C and 0, you can also discuss it with patient, but patients with larger tumor with a T2 or with clinically positive lymph nodes, they receive neoadjuvant treatment with either TCHP, so docetaxel carbo plus dual antibody Herceptin per Perjeta, or ACTHP. Then they proceed to surgery. If there is residual invasive disease, if a PCR is not achieved, they would complete therapy with TDM1 in the adjuvant setting. Otherwise, if there is a PCR, they will complete the dual antibody therapy with HP for a total of 1 year. So triple negative breast cancer has been considered the most aggressive form of breast cancer with less therapeutic options, a higher risk of early relapse and high risk for visceral involvement, including lung, liver, and CNS. It is, however, highly chemosensitive disease, and patients achieving PCR usually have similar outcome compared to other breast cancer subtypes. Again, this is just showing that patients with triple negative breast cancer is responsive to neoadjuvant chemotherapy with outcomes similar to non-triple negative breast cancer. And the benefit of neoadjuvant chemotherapy is, of course, to downstage tumor, to allow additional time for germline mutation testing, to increase, the rate of PCR by using a number of drugs and biologics. And also we have residual disease treatment options, including adjuvant capecitabine, olaparib for patients with a BRCA1 or 2 mutation. This is the keynote study, which is now the standard treatment, and it assessed the role of pembrolizumab of immunotherapy for patients with triple negative breast cancer treated in the neoadjuvant setting. I'm sure you're all familiar with the study. Primary endpoint was PCR, a number of secondary endpoints, and this was over 1,000 patients randomized 2-to-1 to either standard chemotherapy with carboplatin, paclitaxel, and either AC or EC, or the same regimen plus pembrolizumab in the neoadjuvant setting if followed in the adjuvant setting. The results speak for themselves. This is the PCR. If you see significantly superior PCR achieved in patients with received pembrolizumab plus chemotherapy as opposed to chemotherapy alone. Very interesting. It's not necessary to test the PD-L1 status because the benefit was the same. This is something that is important in the metastatic setting when patients have already been exposed to prior chemotherapy. However, in the neoadjuvant setting, probably because the immune system is chemotherapy naive, so to speak, it is not necessary to test, but pembrolizumab can be given to any patients with triple negative disease. So this was the PCR, and then we're looking at the event-free survival. This is the results presented at ESMO last year, showing a statistically significant difference in event-free survival for patients who receive pembrolizumab plus chemotherapy as opposed to chemotherapy alone. And finally, and most important, the event-free survival by PCR. So even patients that did not achieve a PCR had a better outcome with pembrolizumab as opposed to patients who receive chemotherapy alone. And just very recently, so this was pembrolizumab was approved in 2021 for the treatment of patients with high risk early stage triple negative breast cancer based on the increased incidence of PCR and improvement in event-free survival. But just very recently, we had this data published in the New England Journal of Medicine showing also a benefit in overall survival. So patients who receive a combination of pembrolizumab plus chemotherapy not only had improved PCR, improved event-free survival, but also improved overall survival. So this is another success story for this difficult to treat patient subset. There is a downside to this, of course. Immunotherapy has side effects. We always joke and say it's whatever it is. So, that you can have serious side effects. Some of them are easy to manage, such as hypothyroidism, although it can last for a very long time. Patients can develop also hypophysitis, uveitis, pneumonitis, hepatitis, and so forth. So you have to be very careful when you're treating these patients to assess them for adverse events. And also, it's important to remember that this is not only during treatment, however, because the time of onset and toxicity of these adverse events can go, beyond in time, also, after several weeks of treatment. And so one has to be aware of all this possible toxicity. Endocrinopathies, indeed, they can occur at any time during treatment, but certain other toxicity, they can happen even later on, such as kidney toxicity and nephritis. And so again, a very busy slide, but this is for patients with early stage triple negative breast cancer. So if you have patients with a T1C and a 0 in the clinical setting, of course, you can deliver neoadjuvant treatment with taxane and platinum or an anthracycline and taxane containing regimen, and then surgery in case of a PCR, then no further therapy, and instead in case of no PCR, you can give capecitabine. For instead patients with bigger tumor at 2 centimeter and higher or any positive lymph nodes, then these patients would have qualified for the Keynote 522 study with chemotherapy plus pembrolizumab. So this is currently the standard, followed by, of course, definitive breast surgery. If PCR, patients complete 1 year of pembrolizumab. If no PCR, they can still complete 1 year of pembrolizumab, although this is debatable currently, but also they are treated in the adjuvant setting with capecitabine and olaparib in case of a BRCA mutation. For patients with smaller triple negative tumors, they can proceed with surgery first and then discuss chemotherapy regimens, include taxane, carbo, docetaxel, cyclophosphamide. And of course, ongoing trials are assessing tailoring neoadjuvant therapy to response. Is it really necessary to complete a full year of pembrolizumab in patients who achieve a PCR or an inpatient who received no PCR as well? And what about to add a PARP inhibitor in the neoadjuvant setting for patients with a BRCA mutation? For hormone receptor positive, as I mentioned before, it's a little bit different because chemotherapy has less efficacy. It is historical data has shown that neoadjuvant chemotherapy is equivalent to adjuvant in terms of disease-free survival and overall survival, but it's also a neoadjuvant therapy can induce less percentage of PCR as opposed to other breast cancer subsets. You have low rates of PCR in hormone receptor positive disease as opposed to triple negative and HER2 positive. There are also genomic assays that suggest that majority of patients with hormone receptor positive disease will do well with endocrine therapy alone. And neoadjuvant endocrine therapy may also be an attractive alternative for patients with hormone receptor positive breast cancer. So, of course, not all hormone receptor positive breast cancers are alike. There's luminal A and luminal B, and there's diseases that are stronger estrogen dependence and diseases that instead have less of an estrogen dependence and increase proliferation. So the phenotype is diverse, and it's important to assess to tailor treatment for this patient. Why should we use neoadjuvant therapy for patients with hormone receptor positive disease? Well, as we mentioned before, you can downstage the tumor prior to surgery. That is possible to achieve a less aggressive surgery, and also potentially downstage the axillary lymph nodes. Is it possible to use neoadjuvant endocrine therapy? Yes. It is also possible to utilize neoadjuvant endocrine therapy. We can also identify hormone receptor positive tumor that might not require chemotherapy in the future and gain insights into the biology and biomarkers response and resistance to treatment. So this is a meta-analysis which was published a few years ago and basically showed a similar clinical response, radiological responses, and rates of breast conservation therapy with lower toxicity with neoadjuvant endocrine therapy as opposed to neoadjuvant chemotherapy. So this is still a possible approach for certain subset of patients with hormone receptor positive disease. But of course, we have gene expression assays such as oncotype and MammaPrint to determine whether patients will benefit from adjuvant chemotherapy. And so this is the ASCO basically recommendations for patients with hormone receptor positive early breast cancer. If the patients are premenopausal and they have node-negative disease, then you would do oncotype and decide whether chemotherapy is necessary. For patients with node-positive disease, there is insufficient evidence to recommend a biomarker for use, so chemotherapy would be the standard. For patients with postmenopausal breast cancer, you would have, for node-negative disease, oncotype DX or MammaPrint to decide on subsequent adjuvant therapy. For patients with node-positive, if they have 1 to 3 lymph nodes, again, you can do oncotype or MammaPrint. For patients with node-positive disease of 4 or more lymph nodes, there is insufficient evidence to recommend biomarker, and they would be treated with chemotherapy followed by endocrine therapy. So what is our algorithm, basically? In premenopausal patients with node-negative disease, they would proceed to surgery. And then adjuvant therapy will be decided upon the pathology report, of course. For patients with clinically lymph node positive disease, they will proceed with neoadjuvant chemotherapy. In postmenopausal patients, if they have node-negative disease, again, they will proceed directly to surgery. For patients who have a N1 disease or N0 or microscopic N disease, then we would do recurrence score through oncotype to decide adjuvant treatment. For patients who have instead a bigger axillary involvement of lymph nodes, 4 and more, then treatment would be in the adjuvant setting, chemotherapy followed by endocrine therapy. Patients with clinically node-positive disease, they will undergo recurrence score through oncotype. If the score is 0 to 25, then they will undergo surgery first, or they could undergo neoadjuvant endocrine therapy, or of course, enroll in a trial. If the recurrence score is higher, then they would proceed with neoadjuvant chemotherapy. So this is where we're using neoadjuvant chemotherapy for patients with hormone receptor positive disease. So in conclusion, basically, neoadjuvant treatment has a clear role in the management of breast cancer and has achieved a much larger role in recent years as opposed to even 10 years ago. PCR has an established prognostic value, so patients who achieve a PCR are the ones who are going to do better in terms of prognosis. Triage of new agent is, of course, faster and cheaper in the neoadjuvant setting, and we should, do research in the future to identify predictors of both PCR and event-free survival, and also assess best post-neoadjuvant strategies for patients who have achieved a PCR or for patients who have achieved the PCR. And I think that's my last slides. Thank you so much.
Thank you, Dr. Fournier, for this excellent talk. Since we have 3 minutes, I'd like to ask you something, if that's okay. Sure. We already know that the PCR, whenever we see people lecturing about that, not all PCR are the same. So, of course, we need to take in consideration the early stage, right? Like how the patient presented itself or how the disease presented itself. Do you also think that the treatment given to the patient can also alter the prognosis of the PCR? For example, in triple-negative breast cancer, receiving immunotherapy, do you think the PCR with patients who received immunotherapy is different from the ones who didn't?
Oh, so the PCR with immunotherapy, you mean, is different than patients who just received chemotherapy?
Yes, if you think that the prognosis is going to be different depending on which drugs the patient received prior.
Yes. So, this is a little bit, we can go back to to the old meta-analysis, not that old, but 10 years old meta-analysis of Patricia Cortazar. So again, the PCR has a prognostic value in identifying the patients who will do better. So the rate of PCR with neoadjuvant chemotherapy plus immunotherapy is higher. So of course, it will give us the chance to identify those people that are going to have a better outcome, but it might not necessarily. So a higher rate of PCR just means that you are going to best identify those people who are going to have a better outcome in the future. But I don't think there is a difference between a patient that achieves a PCR with standard chemotherapy or a patient who achieve a PCR with standard chemotherapy plus immunotherapy. It's just that by utilizing both modalities, you will have more patients that achieve a PCR. I don't know if
Perfect. Yeah, I think I feel the same. And like changing just a bit for the hormone receptor positive patients. I know that we sometimes, for elderly patients, we use hormone neoadjuvant treatment, but do you also give them to patients who also co-express HER2? For example, you have an 85-year-old patient in your clinic and they both co-express hormone receptors and HER2. Do you do that combined?
So yes, I've done it, but then at the same time, depending on the comorbidities, but for example, patients like, for example, weekly Taxol and Herceptin is very well tolerated. So even in an 85-year-old woman, unless, you can still do that. You can de-escalate the neoadjuvant treatment. You don't need to give them TCHP. You can just give them, 12 weeks of weekly Taxol plus Herceptin, and they can, you can send her into a PCR just with that. We actually did a study at MSK in combination with Dana-Farber, in which we de-escalated with THP, so paclitaxel, trastuzumab, and pertuzumab in the neoadjuvant setting without the anthracycline part. And patients then went to definitive breast surgery, and there was a significant amount of PCR, and therefore I don't think that's super toxic, and I think you could give that to your 85-year-old patient.
Okay, thank you very much.
Thank you, Dr. Fournier. Thank you, Juliana. Okay, we need to continue with the program. We have the last two lectures. So now we will invite Dr. Judy Borgwell from the Breast Cancer Center from the Mayo Clinic. And the moderator will be Dr. Edward Millian. He's from Brazil. Okay, so Dr. Judy, do you want to share your lecture when you want?
Excellent. Yes. Well, good morning, everyone. It's a real pleasure to be here today. And I think I'm the last lecture, so hopefully to take this all home. We are going to talk about the AG3 management of patients with node-positive disease that are treated with neoadjuvant chemotherapy. I think we should have the slides in the right format right now. Yes. So you can see my disclosures, so I'm going to jump straight in. We heard nice talk just now from Dr. Fournier regarding the advantages of the use of chemotherapy in the neoadjuvant setting. And really in terms of the topic that I'm going to be talking about, in terms of AG3 surgery, there are two aspects that are really important from a standpoint of the advantages of neoadjuvant chemotherapy, is both the opportunity to decrease the likelihood of nodal positivity and thus de-escalate the type of AG3 surgery performed. And also, I think it's always important for us to realize that surgical staging of the axilla is an important component of assessing response of the tumor to the chemotherapy. And as we heard, prognostic information in terms of whether there is eradication of disease and the patient achieves the PCR versus whether there is residual disease is critically important in terms of adjusting adjuvant therapies. So in terms of nodal surgery, I always like to stop and just have a high-level question and think to ourselves, why do we even perform surgery on the axilla? And I would say that there are many reasons. One is to guide adjuvant systemic therapy, as we just discussed. Another is also to guide adjuvant radiation therapy, whether radiation is indicated or not, and what fields need to be radiated. From a surgical standpoint, I think we all believe there is advantage to resecting any disease that we know is there and rendering the patient no evidence of disease. And along with that, providing long-term regional control. I think one thing that we have all realized over multiple trials over the last several decades is that AG3 lymph node dissection alone really does not directly impact survival. And so I think one of the biggest questions in this area is whether the role of axillary surgery is just to check whether there is disease in the nodes versus not disease in the nodes, so node negative versus node positive, or how important the number of positive lymph nodes is in terms of the adjuvant recommendations. So we've all seen this dramatic evolution of axillary surgery. Back 15, 20 years ago, we were performing routine axillary lymph node dissection, a very nice, thorough surgical procedure, removing all the level 1, level 2 lymph nodes, 10 to 25 or more lymph nodes removed. However, a significant comorbidity with a lymphedema risk of about 25%. So increasingly, we've looked at de-escalating to the use of sentinel lymph node surgery, which resects on average between 2 and 3 lymph nodes and is associated with a much lower lymphedema risk. And we have successfully de-escalated for those patients that present with clinically node-negative disease and are treated with upfront surgery. And we'll talk today about the management of those patients treated with neoadjuvant chemotherapy. And then probably not relevant for this talk, but I always like to have an eye towards the future. The future potentially may be an era where there is no axillary surgery. Maybe axillary surgery can be replaced with axillary ultrasound, as we've seen with the SOUND trial. Maybe we can identify patients where the risk of nodal positivity is so low we don't even need to do axillary surgery, or maybe where the axillary status does not actually impact the management of the patient. So before I talk about node-positive disease at presentation, I just want to spend a few minutes talking about node-negative disease at presentation. And for many years, there was a huge debate about whether we should be doing upfront surgery versus surgery after neoadjuvant chemotherapy. And I think in patients with clinically node-negative disease, this was nicely kind of cleared up. And the current standard is that we proceed with sentinel lymph node surgery after neoadjuvant chemotherapy. There has been several meta-analyses showing that the false negative rate after neoadjuvant chemotherapy in patients with clinically node-negative disease was low and acceptable at about 6%. And importantly, in addition to seeing similar rates of identification of the sentinel node and similar and appropriate false negative rates, by performing sentinel lymph node surgery after neoadjuvant chemotherapy, you have more patients that are node negative or less patients that are node positive, and thus less patients are subjected to axillary lymph node dissection. And importantly, this does not lead to higher local regional failure rates. Thus, for clinically node-negative disease, the optimal management is axillary surgery after completion of neoadjuvant chemotherapy. If the sentinel lymph node is negative, then that patient can omit axillary lymph node dissection. If the sentinel lymph node is positive, the current standard of care is axillary lymph node dissection. But as we'll see later, this is evolving despite lack of specific data in this area. In the I-SPY 2 clinical trial, looking at data over the 10-year period from 2011 to 2021, there are 732 patients that were clinically node negative. And when you look, you see the vast majority underwent sentinel lymph node surgery, with only a minority going straight to axillary dissection. And what you see dramatically over the course of this decade of time, you can see that the use of sentinel lymph node surgery significantly increased, use of axillary dissection significantly decreasing. When we look at the clinically node-negative patients, those that were selected for axillary dissection, about 50% were node positive, so that tells us there was something that the surgical team identified that led to axillary dissection in that group. In those that underwent sentinel lymph node surgery, which was the vast majority, 91%, majority of those, 89%, were sentinel node negative. Of those that were sentinel node positive, which was 73 patients, only 30 patients went on to a completion dissection, with additional positive nodes identified in about a third of patients. So let's focus now on clinically node-positive disease at presentation. I'm going to pause just to review the AJCC staging criteria for clinical nodal disease. Clinical N1 disease is metastasis to the ipsilateral movable level 1 and 2 axillary lymph nodes. For clinical N1, there is no criteria in terms of the number of abnormal nodes on ultrasound or MRI. To reach clinical N2 criteria, the patient must have clinically fixed or matted lymph nodes. And this is very different to pathological N1, which is limited to 1 to 3 nodes, and N2 being 4 or more. So the number of nodes is not what impacts your clinical stage, it's the physical exam of the axilla. So there have been several trials, the 3 key trials that have looked at sentinel lymph node surgery after neoadjuvant chemotherapy in patients with clinically node-positive disease, mainly focused on N1 disease. And the 3 trials had slightly different inclusion criteria. The Sentina trial included patients that were felt to be node positive, but did not necessarily have a percutaneous needle biopsy, but they did have negative nodes by ultrasound after neoadjuvant chemotherapy and had a false negative rate of 14%. The ACOSOG Z1071 trial required nodal positivity by percutaneous biopsy, also required removal of 2 or more sentinel lymph nodes, had a false negative rate of 12.6%. And then the Canadian SNFNAC trial, very similar inclusion criteria to 1071, but also included immunohistochemistry on the sentinel nodes and categorized isolated tumor cells as node positive, and with that inclusion criteria, had a false negative rate of 8.4%. And when you look kind of across these trials and you look at the meta-analysis, we see a false negative rate of around about 13%. So what we learned from these trials, which were essentially negative trials because they didn't meet their primary endpoint, although they have dramatically impacted clinical practice, what we learned from these trials was multiple methods, kind of a toolbox to help us decrease the false negative rate and allow us to implement sentinel lymph node surgery in this setting. Some of these tools are the use of dual tracers. The study showed that if you use both a radioactive isotope and a blue dye, or at least 2 types of tracer material, it resulted in a lower false negative rate and also improved the sentinel lymph node identification rate. If you're able to resect 2 or more sentinel lymph nodes, then the false negative rate is lower. And what we saw across the trials is that this occurs that in about 72% of cases, patients had 2 or more sentinel lymph nodes resected. With the use of immunohistochemistry on the sentinel nodes to identify low volume disease in the axillary nodes and render those patients as labeled as node positive, the false negative rate was lower, around about 8 to 9%. And then a very interesting subgroup analysis that we identified was that if a clip was placed in the positive node prior to chemotherapy, and that clip node was resected after neoadjuvant chemotherapy, the false negative rate was lower at 6.8%. Now, again, across the studies, you can only really find the clip node probably in about 3/4 or 6% of patients. But when you find that clip node, the false negative rate is lower. And this led to an evolution of clinical technique where nowadays in many centers, we ensure that a clip is placed in the node, and then we ensure that that clip node is resected. And using that along with sentinel lymph node surgery results in a false negative rate of as low as 2.4% in the pivotal trial. So together, these 3 studies, along with the development of targeted axillary dissection ensuring resection of the clip node, has led to the widespread adoption of sentinel lymph node surgery. But I really want to emphasize the caveat. The adoption of sentinel lymph node surgery is appropriate in those patients that have clinical N1 disease. This data is not an N2 or N3 disease, and that we are appropriately selecting those patients that have had a good response to neoadjuvant chemotherapy. Our goal here is to identify the patients that have converted to node negative and thus enable them to forego axillary lymph node dissection. This is not a one-size-fits-all. This is not for every patient treated with neoadjuvant chemotherapy. If patients have disease progression, if patients have residual palpable abnormal disease, then axillary dissection remains the appropriate management. So how do we identify this biopsy-proven node? Well, there are many different ways. And while the most common one that has been described is use of a clip and use of radioactive seed, there are many different options. We can mark that positive node with a clip, with a tattoo using India ink or charcoal, and there are now many other localizing devices that some places are placing in the node prior to chemotherapy. After chemotherapy, we can then localize that marked node with a wire, with a radioactive seed, with many of the other new technology types of seeds that are out there on the market, with the use of intraoperative ultrasound, and never underestimate the use of intraoperative palpation. So here we have a patient with an abnormal node, they undergo a needle biopsy, the clip is placed, and they proceed with a neoadjuvant chemotherapy. After completion of chemotherapy, they have a preoperative localization procedure of the clip node with placement of a radioactive seed or some other kind of localization device in the node. And then they go to surgery where they have standard sentinel lymph node surgery with dual tracer, along with ensuring removal of the clip node. So many centers have adopted that approach. I will spend just a couple of slides on an alternative approach. The group from Memorial Sloan Kettering Cancer Center advocate that maybe we do not need to place a clip in the node. And I think it's important to realize that clipping a node and localizing a node are additional procedures for patients and additional costs for the healthcare system. So at Sloan Kettering, they had 269 patients and they performed sentinel lymph node surgery using the standardized approach of dual tracer. And they have a protocol that requires removal of at least 3 sentinel lymph nodes. So they did not localize the clip node. And if they were unable to retrieve at least 3 sentinel nodes, or if there was any positive disease, they proceeded with axial lymph node dissection. They show that they were able to identify 3 or more sentinel nodes in 93% of the patient population. Among that group, you could see that the clip node was retrieved in 93% of the patient population. And in those where the clip node was not retrieved and the patients did not have an axial lymph node dissection, there was no axillary failures at 55 months. So they really advised that if the sentinel node procedure is optimized with dual tracer and removal of at least 3 sentinel nodes, the clip node is one of the sentinel nodes in the majority of cases, suggesting that nodal clipping does not necessarily need to always be performed. So to summarize, how do we manage the axilla in a patient with node-positive breast cancer treated with neoadjuvant chemotherapy? If I have a patient that comes to me and they did not have a clip or any kind of marking placed in the lymph node at the time of diagnosis, I still proceed with sentinel lymph node surgery. I try to make sure I remove at least 2 sentinel nodes. If any of the nodes are positive, we proceed to axillary dissection. If we have failure to identify the sentinel node, I would proceed to an axillary dissection. And if there's only a single sentinel node, then I would seriously consider an axillary dissection, but also evaluate the response in the breast and ensure I'm proceeding with comprehensive physical evaluation of the axilla. If there was a clip in the lymph node at diagnosis, I do use preoperative localization of that clip node. We routinely perform a specimen X-ray to see whether that clip node was resected. If it wasn't resected, I can use intraoperative ultrasound or palpation to try to identify that clip node. Similar to above, if you have failed lymphatic mapping and you can't find any sentinel nodes, or you really can't find the clip node, consider conversion to ax dissection. If I identify at least 2 sentinel nodes, or 1 including the clip, but even if I get 2 without the clip, then I'm comfortable proceeding based on the pathology from surgery. So if the sentinel nodes are negative, no further surgery. If they're positive, proceeding with axillary dissection. So what are the outcomes when we use this algorithm? This was the early report from 2016 from the Italian group, showing of 147 patients with a median follow-up of about 5 years. They had 1 axillary recurrence, which actually occurred in one of the patients that was sentinel node positive and did undergo an axillary dissection, with no axillary recurrences in their 70 patients that were sentinel node negative. The updated 10-year follow-up now of 688 patients, including both those that were clinically node negative at presentation and those that were clinically node positive. Noting here that all patients, if they were sentinel node negative, did not have completion dissection. Axillary failure rates in the node negative patient of 1.5% and in the node positive patient of 1.8%, really demonstrating that the use of sentinel lymph node surgery is acceptable in those patients that present with clinically node positive disease who become clinically node negative after neoadjuvant chemotherapy. At Mayo Rochester, in my practice, we have seen a dramatic shift in the way we manage our patients over this time course from this paper, which studied 2009 to 2019. We showed that the use of sentinel lymph node biopsy really was able to allow a significant portion of patients to avoid axillary lymph node dissection. When you look here at this graph, you see the yellow line was the use of going straight to axillary dissection for patients that presented with node-positive disease, and that has dramatically decreased. And the blue line shows the increase in the use of sentinel lymph node surgery. Overall, about 52.5% of patients that underwent sentinel lymph node surgery were able to be spared axillary lymph node dissection. But as I focused on earlier, there is still a subset of patients that we elect to proceed directly to axillary lymph node dissection. And when we proceed directly to axillary lymph node dissection, we find nodal positivity in about 65% of patients overall. And over time, this has increased from 55% to 76%, showing that we are increasingly selecting those patients for axillary dissection that have residual disease. Of those patients that had sentinel lymph node surgery and had a completion axillary dissection, we found additional nodal disease in the axillary dissection in 64% of patients, and this percentage was actually pretty stable over time. Very short follow-up, just a median of about 3-year follow-up on this cohort, and you can see no significant difference in regional axillary recurrence or recurrence-free survival. The recurrence-free survival obviously is being driven by being pathologically node positive, but not being driven by the type of surgery performed. This was a pivotal multi-center trial conducted across Europe and America, led by Dr. Walter Weber and Dr. Giacomo Montagna, looking at patients with clinically node-positive N1 to N3 disease that were treated with neoadjuvant chemotherapy and had a nodal pathologic complete response. About 666 had sentinel node biopsy, 478 had targeted axillary dissection, but the key finding here is that the axillary recurrence rate at 5 years was about 1%. So node-positive disease converted to node-negative, low axillary recurrence, and they showed no difference in axillary recurrence between use of sentinel lymph node surgery versus targeted axillary dissection with removal of the clip node. So this is my one and only slide on radiation for this talk, but I do think it's also key to show that those patients that were node positive that have converted to node negative, the NSABP B51 trial randomized those patients to radiation versus no radiation, and they showed no difference in local regional recurrence-free interval, distant recurrence-free interval, distant-free survival, and overall survival between those that received regional nodal radiation and those that did not receive regional nodal radiation. Now, this trial was being conducted while the shift in axillary surgery was occurring. So about 55% of patients on this trial had sentinel lymph node surgery. About 45% of patients on this trial had axillary lymph node dissection. You can see the rates of PCR in the breast were relatively high at 78%. So this is a selected group of patients that had PCR in the breast, nodal complete response, and that this select group of patients is well positioned to consider de-escalation of radiation as well as de-escalation of surgery. So pivoting back to the I-SPY2 clinical trial, that 10-year cohort, this is now looking at those patients that were clinically node positive before they were treated with neoadjuvant chemotherapy. And you can see that about half of them had axillary dissection, half of them had sentinel lymph node surgery. And again, we see this dramatic change over this decade of time from 2011 to 2021. You can see here where the 1071, the Centina trial were reported at San Antonio, and you can see a significant de-escalation in use of going directly to axillary lymph node dissection and a significant shift with the use of sentinel lymph node surgery. And this was true across all tumor biologic subtypes. When we focus in on this group, we see that about half had an axillary lymph node dissection. And again, we see we're selecting those patients well. Of those that were selected for axillary dissection, 63% were node positive at axillary lymph node dissection. When we look at the 52% that had sentinel lymph node surgery, 62% were node negative. So again, good selection by the clinical team. Of those that were node negative, some did go on to axillary dissection. But in those that were node positive, which was 38%, the ones that went on to completion axillary lymph node dissection, the rate of additional positive nodes at surgery remained high at that 60% range, as we've seen in other reports. The nodal positivity rate in those that had axillary dissection alone remained high, about 61%. And again, here, as we saw from the previous trial, the rates of nodal positivity are higher in hormone receptor positive HER2 negative disease and lower in triple negative and HER2 positive disease, as one would anticipate. So, now that we've done sentinel lymph node surgery and we've established that a patient has a positive sentinel node after neoadjuvant chemotherapy, how do we manage those patients? Well, as we've talked about, if the sentinel lymph node is positive, with either micromets or macromets, the likelihood of having additional positive nodes on completion dissection is high at 60%. This is very different to the group of patients treated with upfront surgery. We know that those patients that do have additional positive nodes, the factors associated with that tends to be HER2 negative disease, multifocal multicentric disease, macrometastatic disease, and the number of positive sentinel nodes. So many people talk about the AMROS trial and say, well, can we extrapolate the AMROS trial into the post-neoadjuvant setting? AMROS, of course, as we all know, enrolled those patients with clinical T1, T2 disease, clinically node negative, that had found to have positive sentinel node, and showed a low 5-year axillary recurrence rate of 0.43% in those with dissection and 1.19% in those with radiation. But this was a different cohort. Only 33% of these patients had additional positive nodes on axillary dissection, with only 8% having 4 or more additional positive nodes. So when we asked the question about whether AMROS can be extended to those patients that have node-positive disease after neoadjuvant chemotherapy, we have to realize that AMROS was clinically node negative. For patients treated with neoadjuvant chemotherapy, most of these are clinically node positive. AMROS had T1 to T tumors. Many patients treated with neoadjuvant chemotherapy are T1 through T4 tumors. AMROS is predominantly ER-positive disease. Patients treated with neoadjuvant chemotherapy are more likely to have unfavorable tumor biology, such as triple negative or HER2-positive disease. Amrose had predominantly low volume nodal disease. Neoadjuvant chemotherapy, you're more likely to have higher burden nodal disease. With Amrose, they obviously did not have neoadjuvant treatment, and they're still getting their best treatment as the adjuvant setting. In the neoadjuvant setting, these patients have had their best treatment already, and they have persistent disease despite having received neoadjuvant treatment. So I would argue that these two are very different categories. So if we have a patient that has a sentinel node that's positive after neoadjuvant chemotherapy, the advantage of axillary dissection is we allow us to remove the additional positive nodes. The number of involved nodes is not reliably identified from imaging, and so by removing these nodes surgically, we can identify the residual nodal burden, which will not only impact the medical oncologist and the radiation oncologist recommendations for additional therapy, but also influence the patient's compliance with these recommendations. But the downside for the axillary dissection is it does have a higher lymphedema rate. We know it provides good local control, and we know it really probably does not impact survival. Axillary radiation, on the other hand, we know is good at controlling low volume disease. If we treat with axillary radiation, though, we don't know the residual nodal burden in the axilla. We don't really have data on the long-term axillary control with radiation alone with higher volume disease in the axilla, but we do know it's associated with a lower lymphedema rate. So we await the results of the Alliance A11202 clinical trial. This has completed enrollment and randomizes these patients with node-positive disease to axillary lymph node dissection versus radiation. And we look forward to seeing the results of this trial. In the meantime, we can look at the patients that were managed on the I-SPY 2 clinical trial. And this is now slightly different data. This is now looking at those that were pathologically node positive. So regardless of what their clinical stage was prior to chemo, these are the ones that had persistent nodal disease at surgery. And it's striking to see that surgeons and patients are already voting with their feet. And we're already seeing a de-escalation in the use of axillary lymph node dissection in this patient population, despite the absence of data. And this has been occurring while the clinical trial was running and persisting even after that trial closed. And we have seen this trend across all subtypes of breast cancer. When we look at some of the early data out of the I-SPY clinical trial, looking at the axillary recurrence, on the left side, we see those that were pathologically node positive. On the right side, we see those that were left side pathologically node negative, right side pathologically node positive. We see there was not a significant difference in axillary recurrence rates between those treated with sentinel lymph node alone versus those treated with axillary lymph node dissection. We look at local regional recurrence. Again, we see no significant difference between the two. We actually see higher local regional recurrence rates in those with axillary dissection, likely reflecting that these are patients that are at higher risk of disease and appropriate patient selection for axillary dissection. And again, with distant recurrence-free survival, we see very similar results regardless of the type of surgery. And with event-free survival, again, no significant difference. The one difference that is significant is poorer outcome with those that had the axillary dissection, again, reflecting appropriate patient selection. What we showed in this paper from I-SPY 2 was that both in node negative and node positive disease after neoadjuvant chemotherapy, omission of axillary dissection did not negatively impact axillary control, local regional control, distant recurrence-free survival, or event-free survival. We did show, as one would anticipate, that higher pathologic T category, so more residual disease in the breast, was associated with poorer oncological outcomes, and that tumor biology remained key, with triple-negative breast cancer being associated with poorer event-free survival and poorer local regional control. So really, the data from this showed that the extent of residual disease and tumor biology are the critical factors that impact outcome, but the actual type of surgery likely does not impact oncological outcomes. So in summary, to take us home for this conference today, those patients that were clinically node negative at the time of presentation and are treated with neoadjuvant chemotherapy, standard recommendation will be sentinel lymph node surgery to assess the axilla after chemotherapy. If node positive, standard of care is axillary dissection, but it's reasonable in 2024 to be considering axillary dissection versus radiation while we await further data in this area. For those patients with clinically node positive disease, with specifically N1 disease, sentinel lymph node surgery after neoadjuvant chemotherapy in appropriately selected patients, i.e. those that have a good clinical and imaging response in the breast and the axilla, we recommend the use of dual tracer, resection of the clip node, and use of immunohistochemistry. If the sentinel node is positive, current standard is axillary dissection while we await the results of 11202 and the TAXA studies, but already patients and physicians are leaning towards considering the use of dissection and considering the use of radiation in place of dissection in specifically selected patients. I hope many of you will consider joining us in Las Vegas for the upcoming annual meeting of the ASBRS, and I appreciate everyone's attention today. Thank you.
Thank you very much, Doctor. Now we stay with a few questions for Dr. Edward Millian. Thank you, Doctor.
Thank you to be here. I would like first to my invitation to participate at the Umberto Veronese Academy Symposium. I think that it's a way to remember Professor Veronese's legacy and his memory. For Dr. Judy, congratulations for your outstanding presentation. I think that you concluded very well in patients that received neoadjuvant chemotherapy and is still alive with the positive sentinel nodes. There is no way until we receive the results of the change in practice, maybe Texas and the Z10, the last ACOG study. But in patients, in luminal patients, very selected patients, they sometimes should be treated with neoadjuvant hormone therapy. And for these patients that continue with sentinel node positive, do you think that should be treated exactly as patients that received neoadjuvant chemotherapy, or we can reduce the axillary surgery for them?
Well, thank you, Dr. Millen. That's an excellent question, and I think a very challenging question. I think all of the data we have is related to neoadjuvant chemotherapy. So the data regarding de-escalation of surgery in those treated with neoadjuvant endocrine therapy is very sparse. We know that the nodal eradication rates with neoadjuvant endocrine therapy are significantly lower than what we see with chemotherapy. The original studies were down in the kind of single percentage digits. There have been some more recent studies maybe showing you can have eradication of disease in maybe 10 to 20%, but it's not the 60% rates that we're seeing with neoadjuvant chemotherapy, especially in the HER2 population. So I think that's always very important for us to remember. So if you have a patient that really has significant volume of nodal disease in the axilla and they're treated with neoadjuvant endocrine therapy, most likely they're going to have persistent disease. And in those situations, I'm usually going to lean towards an axial lymph node dissection. Now, if the imaging shows a good response in the axilla, I often will give that patient the opportunity for a sentinel node surgery along with resection of the clip node to assess the volume of residual disease. And if they have had eradication of disease and I have a good surgical sampling of the axilla, then we can forego axillary dissection. But I think it's important for the patient to realize the chances are much lower than what they are with neoadjuvant chemotherapy. Now, the other question, though, that comes into play is what about those patients that have just a single abnormal lymph node in the axilla? And let's say luminal breast cancer. And the question is, do we go with neoadjuvant therapy or do we go with upfront surgery? And in those cases where it really is like the lymph nodes look normal, there's one lymph node that has just a little bit of cortical thickening, we do an FNA and that node is positive, then in those situations, either would consider upfront surgery and evaluate the axilla and enable that patient to have the opportunity to be treated like a Z11 patient if we prove there's only one or two positive nodes with breast conservation, they can forego axillary dissection and be treated with radiation. But I also often with those patients will consider treating them with a neoadjuvant endocrine therapy and then almost treating them similar to the upfront setting. Do a sentinel node surgery, look critically at the nodal burden, and if it's really just a single positive sentinel node and they still meet that Z11 criteria, even though they've had neoadjuvant endocrine therapy, I would consider avoiding axillary dissection and treating them with radiation.
Okay.
Thank you very much, Dr. Judy. Thank you very much, Eduardo, for showing us. But we need to continue. We have the last presentation, so we continue with the program. Thank you both.
Thank you. Bye.
Seguimos entonces con la próxima conferencia, también una conferencia grabada, en este caso del doctor Curigliano. Giuseppe Curigliano, director de la División de Nuevas Drogas, vicedirector científico del Instituto Europeo de Oncología, quien nos hablará sobre el tratamiento del cáncer de mama HER2-low, y va a estar moderando el doctor Ernesto Gildesa, oncólogo clínico, director de investigación y docencia del Instituto Henry Moore, quien hará una reflexión final posterior a la presentación.
Ladies and gentlemen, good afternoon. It's really my pleasure to be here with you with the Latin American Association of Medical Oncologists and Surgeons. I will discuss specifically about treatment of HER2-low breast cancer. These are my potential disclosures. As you know perfectly, before the era of trastuzumab deruxtecan, the only patient population eligible to an entire HER2 treatment was the HER2 immunohistochemical 3+, or the FISH amplified population. So a very small rate of patients with metastatic breast cancer and early breast cancer were eligible to entire HER2 therapy, 10 to 15%. Everything that was 1+, 2+ with each non-amplified or either HER2 immunohistochemical 0 was considered HER2 negative. With the era of trastuzumab deruxtecan, now we expanded the use of trastuzumab deruxtecan in HER2 positive disease, considering HER2 expression as a continuum starting from HER2 ultra-low, including immunohistochemical more than 0 and less than 10%, and expanding to 1+, 2+, and of course 3+. The first time HER2-low was defined was in the context of NSIDP B47. This was a large adjuvant prospective randomized trial evaluating the activity of trastuzumab in the adjuvant setting in patients that have been defined as HER2-low, immunohistochemical 1+, 2+, and each non-amplified. Patients have been randomized to standard chemotherapy plus or minus trastuzumab for 1 year, and the final results that have been presented in San Antonio 2019 and then published on JCO were completely negative. So another confirmation that a standard antibody cannot target the patient population with HER2-low disease. What's about ADCs? T-DM1 was approved in 2012 for HER2 positive metastatic breast cancer and in the adjuvant setting for those patients with residual disease after neoadjuvant chemo plus entire HER2 therapy. T-DM1 was tested in a patient population with metastatic disease harboring HER2 1+ or 2+ immunohistochemical expression of HER2. Response rate was very low, 4.8%, and so no activity was described for TDX. The revolution arrived with the new generation ADCs, novel conjugates like topo-1 inhibitors, higher drug antibody ratio, cleavable linker, and finally novel payload. This is the key, of course, for the construction of trastuzumab deruxtecan, that is an entire 2 antibody drug conjugated, with a linker that is protease cleavable, and the novel topo-1 inhibitor membrane permeable, highly potent, with a drug antibody ratio of 1:8. What's about the new generation of clinical trials? We know perfectly that HER2-low may account for 60% of HR positive disease and 40% of HR negative disease. So there was really the opportunity to test the activity of this antibody drug conjugate in a large population of patients. HER2-low is not a biological entity. We did a very nice debate together with Sarah Tolane in San Antonio Breast Cancer Symposium, and we concluded clearly that HER2-low cannot be considered a biological entity. The majority of HER2-low triple negative are finally basal-like tumors, and the majority of HR positive HER2-low are, according to PAM50, luminal cancers. And there is no prognostic impact because prognosis is mainly related to the level of expression of estrogen receptor. The lower is ER, poorer is the prognosis. So it's independent on HER2 low. That's why in many retrospective analyses that have been published, the majority of them found no overall survival differences between HER2 low versus HER2 zero breast cancer. The first study to evaluate activity of trastuzumab deruxtecan in HER2 low disease was the DESTINY-Breast04. Prospective randomized trial including patients with immunohistochemical expression 1+, 2+ over 2, each non-amplified. Patients received at least 2 lines of previous chemotherapy and have been randomized to trastuzumab deruxtecan versus chemotherapy of investigator choice. The primary endpoint was median progression-free survival according to blinded independent central review. The key secondary endpoint was PFS for all patients and overall survival. In this study, we had a longer follow-up that had been presented at ESMO Congress 2023, and it's just to remind to you the patient population included in the DESTINY-Breast04 was immunohistochemical 1+ in 58% of the patients, immunohistochemical 2+ with each non-amplified in 42%. 499 patients were HR positive. There was a small cohort of patients that was HR negative, 58 patients. The majority of patients received 2 lines of treatment, mostly 67% more than 3 lines. When evaluating a previous treatment, CDK4/6 inhibitors were received by almost 70% of the patient population in the DESTINY-Breast04. Response rate was impressive. 52% of patients in their HER2 low HR positive population achieved a partial response, 3.6% of them a complete response, and in hormone receptor negative, almost 50% of them achieved a complete response. Importantly, the hazard ratio for benefit from trastuzumab deruxtecan was very similar when evaluating finally median PFS in immunohistochemical 1+, 10.3 months, or 2+, 10.1 months, with an impressive overall response rate that was closer to 52%. With a longer follow-up, and with 32 months of median follow-up, there is still a benefit in median progression-free survival with trastuzumab deruxtecan from 4.2 months to 8.8 months, and also an overall survival benefit from 16.8 months to 22.9 months. The rate of ILD did not increase despite a longer treatment exposure. In the final results of the DESTINY-4, 45 patients experienced an ILD that was centrally adjudicated, 12.1%, and only 4 patients died for ILD. We had some data on post-treatment. Sacituzumab govitecan was the most common drug delivered, but some patients also rechallenged with trastuzumab deruxtecan. The next question was, what if we anticipate the use of trastuzumab deruxtecan? So rather than giving TDX following chemotherapy, what if we give following endocrine therapy plus CDK4/6 inhibitors? Why this question? Because following CDK4/6 inhibitors, the treatment cannot provide a very huge activity. The median PFS for capivasertib plus endocrine therapy was 5.5 months in this patient population, with endocrine therapy alone is 2.6 months, with single agent chemotherapy only 7 months. So why is important? Because if we anticipate an optimal treatment earlier, we can much more impact on overall survival. And the second question, what is the activity of trastuzumab deruxtecan in patients with a lower expression of HER2? I mean, any staining more than 0% and less than 10%. This was why we designed the DESTINY-6, to answer 2 questions. Activity before chemotherapy, activity in HER2 ultra-low population. The DESTINY-6 was a prospective randomized trial including patients with immunohistochemical 1+, 2+, 0 according to ASCO-CAP, with the membrane staining more than 0% and less than 10%. Patients were chemotherapy naive. No one of them received chemotherapy. Or we included also patients who progressed within 6 months after starting on adjuvant endocrine therapy. But a minimum of 2 lines were the majority of the patients. The primary endpoint was median PFS in HER2 low population. The key secondary endpoint, PFS in blinded independent central review in the intent to treat population, including HER2 low and ultra low. Chemotherapy options were capecitabine, nab-paclitaxel, and paclitaxel, the most common chemotherapeutic agents used. We never use anthracycline at the first line setting. We screened 1,349 patients. We randomized 866, of which 59% received capecitabine, 24% nab-paclitaxel, 15% paclitaxel. Median duration of follow-up was 18 months. So which is the activity of TDX in this patient population? First, the majority of the patients, 67% of them with liver mets, only 3% with bone mets. So the main message is that this is really a real-world population, and patients progressing to CDK4/6 inhibitors are not low tumor burden. In the majority of the cases are patients with visceral mets. Almost 70% of the patients received CDK4/6 inhibitors. You can check here 90% in the intent to treat. Many of them received also a second-line endocrine therapy. We have a cluster of patients, 9%, who progressed within 6 months after starting the first-line CDK4/6 inhibitor. This is an important patient population, and some data on this cluster will be presented in San Antonio 2024. Trastuzumab deruxtecan demonstrated a statistically significant and clinically meaningful improvement in PFS when compared with standard of care, with an improvement of PFS from 8 months to 13 months and a delta of 5.1 months with an hazard ratio of 0.62. When evaluating the secondary endpoint, PFS in intent to treat, so HER2 low and ultra low, median PFS was exactly the same, improved from 8.1 months to 13.2 months, hazard ratio 0.63. What's about overall survival? We performed a landmark analysis with 40% of the maturity of the data, but trastuzumab deruxtecan seems also to demonstrate overall survival benefit in this setting, despite 21% of the patients received TDX after chemotherapy. Also in the New England Journal of Medicine paper recently published, we clearly stated that it's impossible to see an overall survival benefit in the DESTINY-6 since all patients on chemotherapy crossed over on TDX. In HER2 ultra-low population, we observed exactly the same benefit from trastuzumab deruxtecan with an improvement from 8.3 months to 13.2 months. Also, trend for overall survival benefit was observed. What's What about response rate? So first, median PFS was confirmed in all the subgroups of the Destiny-6, independently of age, immunohistochemical level of expression, number of prior lines of endocrine therapy, endocrine resistance primary versus secondary, and liver mets or not. But when evaluating the response rate, you would agree with me that response rate is impressive in this patient population. 57% in the patient population with the intent to treat, and 61% in their two ultra low, with 5% of patients achieving a complete response in this group. The most common toxicity was, of course, related to ILD for trastuzumab deruxtecan for treatment discontinuation, and to peripheral neurosensoropathy in the patient receiving chemotherapy. When evaluating dose reduction, the major reason for dose reduction was nausea in trastuzumab deruxtecan arm and hand and foot syndrome in the chemotherapy arm. We observed no new safety signal in the Destiny-6, so finally toxicity was very similar to the Destiny-4, nausea, fatigue, neutropenia. ILD was reported in 11% of the patients, 3 patients died, but no new safety signals have been observed. According to the Destiny-6, now we expanded the potential use of trastuzumab deruxtecan, not only in their too low population, but also in patients with their too low and their too low immunohistochemical expression HER2 between 0% and 10% without previous chemotherapy. And I really believe this is a new treatment options in patients with their too low and their too ultra low HR positive metastatic breast cancer after progression to 1 line or 2 lines of endocrine therapy plus or minus CDK4/6 inhibitors. During ESMO this year, we presented some data on HER2 testing. I believe this is an important point to be discussed. The majority of the patients in the Destiny-6 have been tested on the metastatic sample, 1,537 samples, but some of them on the primary tumor, because some of them were de novo metastatic. When evaluating the immunohistochemical HER2-0 population, so those that have been tested as HER2-0 locally, in order to be eligible to the patient population HER2 ultra-low, 35% of them were HER2 null, so no staining for HER2, but 40% of them were HER2 ultra-low, and 24% HER2 low. We cannot tell that this is a discordance rate because it was not mandatory for the local center to evaluate any staining in HER2-0, but the data that 24% of them were HER2 low, this is surprising for me, because as I said, it's necessary that pathologists really test for the HER2 low expression and should report on the pathology report if 1+ or 2+, or eventually if HER2-0, they should report more than 0 and less than 10%. So a majority of patients with the local HER2 immunohistochemical 0, of course, were centrally scored where they're too low, 24%, or too ultra low, 40%. So which is the conclusion of Destiny-4 and Destiny-6? We expanded the use of trastuzumab deruxtecan to a larger population. So the patient population potentially not eligible to TDX account for 15 to 20% of the overall population. Essential and key will be the work of our pathologists that should test for immunohistochemical 1+ and 2+, and should report in the pathology report any staining more than 0% and less than 10%. That's why within ESMO, we did this working group, very criticized, but I believe that this is really important. Don't forget that TASCO CAP was established to identify the patient population eligible to trastuzumab. That was the original idea behind ASCO-CAP. Now we have a new agent that is very active also in HER2-low and ultra-low disease, so it's time to reevaluate the ASCO-CAP. What's about the new treatment algorithm? Of course, once TDX will be approved in HER2 ultra-low population, you will have the chance to consider TDX as an alternative to standard chemotherapy after CDK4/6 inhibitors, exactly here. And of course, the only patient population for me eligible to sacituzumab govitecan will be the HER2 null, no expression of HER2. Thank you very much indeed. I will be very happy to take questions and I will be connected, of course. Thank you so much.
Muchísimas gracias por esta excelente presentación y creo que accidentalmente el curso nos enfrenta al finalizar el desafío más importante que tenemos en mastología en estos momentos, ¿no? Claramente los tumores HER2-low transforman a la patología mamaria en el tumor más frecuente con el que nos podemos enfrentar. Y eso nos desafía desde el punto de vista ético y nos desafía desde el punto de vista científico. Nos desafía desde el punto de vista ético porque el trastuzumab deruxtecan podría pasar a ser la droga más utilizada en la patología más frecuente de la oncología clínica en todos los países. Y esto hace que en los países tengamos un desafío importante de accesibilidad al tratamiento. Y el segundo punto que nos desafía es de nuevo a la pregunta con la que empezó este curso del doctor Japaze al doctor Viale, dos de los más grandes patólogos actuales en patología mamaria. ¿Cuál es el rol del patólogo en la actualidad y a qué nos desafía esta teranóstica, ¿no? Esta combinación de terapéutica y diagnóstico? Porque fíjense ustedes que el diagnóstico de malignidad y el diagnóstico de invasividad sigue estando centrado en un patólogo que mira por un microscopio. Y luego viene toda la subtipificación molecular que nos permite identificar los tumores de acuerdo a su perfil molecular. Y allí es donde la inmunohistoquímica en estos HER2-low juegan un rol, con lo cual la primera pregunta es ¿cuál va a ser el rol de la inteligencia artificial en la determinación de los pacientes HER2-low verdaderos? Aquellos que están entre 0 y 10% de tinción de la superficie. Y claramente esto nos vuelve a poner frente al desafío de cómo lograr que nuestros pacientes obtengan la mejor sobrevida con la mejor calidad de vida. Y esto es el objetivo de todos estos cursos, ¿no? Actualizarnos, aprender y reflexionar sobre los desafíos a los que estamos enfrentados en el momento actual. Muchas gracias nuevamente, Karina, Darío y Gabriel, por la invitación. Gracias.
Muchísimas gracias, doctor Gil, de esa excelente reflexión, y es esto, ¿no? Llamarnos a la reflexión de nuestra práctica diaria. Muchísimas gracias. Vamos, Darío, a mostrar, por favor, lo que va a ser el certificado que van a recibir quienes van a participar. Esto va a estar disponible a partir de la segunda semana de noviembre y lo van a recibir vía mail. Así que todos tranquilos que van a recibir. No hace falta enviar ninguna constancia. Con el hecho de haber estado participando durante el Zoom, nos queda esa constancia y le vamos a poder enviar a partir de la segunda semana de noviembre. Vamos a hacer también...
Exactamente, Cari, eso es importante, a que lo esperen para recibir. Y lo otro, que van a estar las clases disponibles, todas las clases que se dieron, o sea, tanto la semana pasada como esta, va a estar todo disponible en la página web de Tecnoimagen para que la puedan ver las veces que sea necesario durante 2 semanas aproximadamente. Después de las 2 semanas, las clases se van a descolgar. Pero si alguien quiere volver a ver las clases, las puede llegar a ver sin ningún tipo de inconveniente. Recordar que viene el curso en marzo del 2025, ya le va a ir llegando todo también a través de Tecno, y también va a estar el presencial, que va a ser entre finales de junio y principios de julio del 2025. ¿Y qué vamos a hacer, Cari? ¿Sorteamos ahora los ebook para
Vamos a
todos los que
sortear los
estuvieron?
ebooks, exactamente, quienes participaron durante el primer sábado y este encuentro. Van a ser 6 ebooks en total, 4 del Instituto Europeo de Oncología y 2 de mi autoría. Vamos a los 4 primeros ganadores, van a llevarse el ebook del Instituto Europeo de Oncología, y el quinto y el sexto ganador van a llevar un ebook de signos en imágenes mamarias. Así que
Exactamente,
vamos.
tienen que estar presentes, así que cuando sale el nombre, seguramente los chicos, Alex o Ete, los va a estar buscando o les va a dar el lugar como para que puedan avisar que están, porque se va a sortear. Los primeros va a haber 6 y va a haber suplentes por las dudas que no estén presentes, así honramos el compromiso que dijimos que todos tenemos que estar en el último momento. Así que, Alex, cuando quieras, hacemos el sorteo, o ya estamos jugados en los tiempos.
Muy bien, hay 341 personas que se inscribieron para participar en este sorteo, así que ahora Ethel va a lanzar el lanzamiento. Recuerden, los 4 primeros ganadores van a llevarse un ebook del Instituto Europeo de Oncología sobre controversias y manejo del cáncer de mama, y el puesto quinto y sexto un ebook sobre signos en imágenes mamarias. Bueno, acá tenemos ya subido todo y vamos a ir viendo en vivo quiénes van a ser los ganadores. Tienen que estar en este momento presente. Vamos a ver el suspenso. Bueno, la primera ganadora es la doctora Carmen Villaverde, segundo Andrade Irusta, tercero Edel Iglesias y cuarto Amanda Arrasco, que serían los ganadores del ebook del Instituto Europeo de Oncología, si se encuentran presentes, ¿no?
Exacto.
Exacto.
Quinto y sexto, quinto el doctor Rodolfo Gustavo Capozzi, y sexto la doctora Nora Arcelia Rodríguez, que serían los ganadores del ebook de signos y síntomas de la doctora Karina Pese. Y bueno, ahí están los suplentes, querés pasarlos, así los ven todos. Sabrina Vázquez Bello, Jorge José Alberto Ochoa Pérez, Juan José de Alosio, Iván Azaroff, Edith López, Leslie Dalina Valverde Delgado, y nos quedan 4 más, que todos estos van a ir entrando en caso que los primeros 6 no estén presentes, se va a ir portando uno por uno. Tenemos a Janet Canizales, Walter Dario Acosta, Miriam Giovanna Barrios y Carreras Mauro Iván.
Muchísimas gracias por haber estado conectados estos 2 sábados. Agradecerles al Instituto Europeo de Oncología, a los directores de la Umberto Veronesi Academy, al doctor Farante, doctor Frazón y doctor Rancati, por darnos esta oportunidad. Agradecerle a los directivos de Tecnoimagen que hacen posible que dispongamos de esta tecnología de Zoom, la posibilidad de la interpretación. Un agradecimiento especial, como siempre dicen, al detrás de cámara, que son a Ethel, a Alex, a las intérpretes que nos están en este momento ayudando, a Gabriela, a Doralia y obviamente a mi coequiper, al doctor Dario Schejtman. ¿A quién los queremos invitar a sumarse? ¿Dónde, Dario?
Bueno, los invitamos, como todos saben, a la página de Facebook de la Comunidad Latinoamericana de Imágenes Mamarias, también a la página de Instagram, donde vamos a estar comunicados y poniendo también todas las últimas novedades, y donde van a aparecer las fechas de los próximos cursos. Me sumo en el agradecimiento a todos, a la gente de Tecnoimagen, sobre todo en este curso a Alex y a Ethel, a las 2 maravillosas intérpretes que nos acompañan ya, creo que hace 4 años. Realmente muchas gracias por todo el esfuerzo que ponen. Y bueno, los esperamos, como ya dijo Gabriel, esto sigue. Este próximo curso de IEO serán los primeros 2 sábados de noviembre del año 2025. Y no quería dejar de agradecer también a Gabriel, porque realmente es el esfuerzo enorme que hace para que esto sea posible, para que el IEO, una institución tan importante, nos traiga a todos estos oradores internacionales de primer nivel. Así que muchísimas gracias. Cari, cerramos con esto lo del curso. nuevamente que sepan que van a tener el certificado todos los que hayan cumplido y lo van a tener a partir de la segunda semana de noviembre. Y muchas gracias. No nos queda más que agradecer. Si quieren todos prender las cámaras de los que nos acompañan, así todos los pueden ver. Y terminamos un poquitito pasados hoy, pero bueno, para que todos puedan aprovechar un día lindo, que creo que sí en la Argentina, y un buen almuerzo de sábado. Muchísimas gracias.
Gracias, Alex, gracias, Ethel. Muchísimas gracias a todos ustedes que se conectan desde distintos puntos de Latinoamérica, de Europa. Muchísimas gracias, gracias a los disertantes, gracias al doctor Ferrante por esta oportunidad que nos brinda toda Latinoamérica de poder acceder a contenidos de alto nivel en forma totalmente gratuita. Así que van a estar disponibles las presentaciones, como dijo Darío, seguramente en el canal de YouTube para que ustedes puedan visualizarlas durante 2 semanas. Muchas gracias. Gracias a todos.
Gracias, Cari. Un agradecimiento especial para vos también, que el esfuerzo y por compartir conmigo estas maneras que se transforman en muy prometedoras y nos llenan de orgullo. Realmente puede ser todo eso. Así que gracias, Cari, por estar siempre ahí apoyando. Saludos para todos. Hasta dentro del año que viene.